So anything that causes hypoxia can cause lactic acidosis, and if hypoxia is responsible for lactic acidosis, we call it as type A lactic acidosis. Now the major cation in human body is going to be sodium. Now how do I differentiate whether it is Crigler-Najjar, Gilbert, or whether it is Dubin-Johnson? Simple. All you need to see is what is the predominant bilirubin here. All of the following are extrahepatic manifestations of hepatitis C, except, or which of the following is not an extrahepatic manifestation of hepatitis C. Majority of the liver transplantations that happened following acute liver failure were because of the hepatitis E acute infections. Antibodies and histopathological changes both are there, but no symptoms. That is subclinical celiac disease. Welcome everyone to this ASAP batch test and discussion for medicine. So here we're going to discuss all the questions that were shared with you. I do agree that some of the questions were a bit tricky or even at times controversial. So I'm here to give you the answers for all the questions. Now the most important thing is when we deal with the test and discussion, we should basically learn the knack of solving the MCQs. It is not about information overload, right? Because you know the information, it is there in your books, notes, as well as your regular video lectures. So here we will try to learn how to apply that information to solve an MCQ, right? Now, without wasting my time, here is our first question. Now, in this question, if you have already solved, what was your answer? So, this is a question where the complaint is of a newborn, right? The newborn is having complaints of rash, which we can see in the image, right? So, this is the rash that the newborn is brought with. And the question mentions history of patient mother, means the newborn's mother was also having history of dry mouth and dry eyes. So that is basically talking about what? This is basically talking about Sika syndrome as a manifestation, right? Sika syndrome or secondary Sjogren's is a possibility. And then on examination, the baby's vitals were normal, but ECG showed a conduction abnormality. Basically, patient has got a AV blocks, right? AV blocks. Now here patient's mother is also complaining of a rash that becomes worse on sunlight exposure. So we have a photosensitive rash. She has features of secondary Sika syndrome. And then she has given birth to a baby who also has a rash. Now this makes me think that this is probably a case of this baby is suffering from neonatal lupus, because the mother's history is consistent with lupus nephritis. The diagnosis systemic lupus erythematosus. So for me, the mother's diagnosis would be SLE and the baby's diagnosis would be neonatal lupus. Now the question is, which antibody correlates with the risk of neonatal lupus, right? So those mothers who have SLE and carry this anti-Rho antibody, which is also known as anti-SSA antibody, carry the high risk of developing lupus, and this antibody correlates with not only the risk of neonatal lupus, it also correlates with the risk of developing the subacute. When we talk about the dermatological manifestations of SLE, we categorize them into acute, which is classically your malar rash. Then you have subacute cutaneous lupus erythematosus, and the risk of subacute lupus cutaneous erythematosus correlates with the presence of this anti-SSA or anti-Rho antibody. Second thing it correlates with is the risk of developing the secondary Sjogren's syndrome or the Sika syndrome. And third, it correlates with the risk of developing neonatal lupus. And in neonatal lupus, the concern is the patients with neonatal lupus have the tendency to develop what we call as AV blocks or conduction abnormalities, right? So this is a case where we have AV blocks. So everything fits into the picture. Mother had SLE. Now the baby has neonatal lupus because of the transfer of antibodies from the mother, and the most important antibody here has to be anti-Rho antibody, making option D as the answer for this question. Okay. Now the next question, true about SLE is, okay. First statement is anti-dsDNA is used for screening. This is a false statement. Well, the point that we need to know about anti-dsDNA is it is the second most common as well as second most specific. It is the second most common and second most specific antibody when it comes to patients with SLE. Then what is the most common antibody in SLE? The most common antibody in SLE is going to be your ANA, right? And because of that, ANA is used as a screening test. ANA is used as a screening test, not the anti-DS DNA. Okay. Then also comes a question, what is the most specific antibody? The most specific antibody in SLE is going to be your anti-Smith antibody. Anti-Smith antibody. These two are important take-home messages. Okay. Now coming to option B. STAT4 is associated with lupus nephritis. See, now all patients of SLE do not go on to develop the lupus nephritis. There are certain predictors like, okay, you have SLE and you have these additional pointers, then your risk of developing lupus nephritis is high. What are those predictors? The predictors of lupus nephritis in a patient with SLE. Okay, the first thing I want you to know is high anti-DS DNA titers. High anti-DS DNA titers. Okay. Second thing I want you to remember is the mutations in STAT4 gene. STAT4 gene mutation is associated with increased risk of developing lupus nephritis. Okay. Then third, so this is as of now a true statement. Option C, smoking is not associated with lupus, is obviously false, because what we have studied in SLE is smoking is a risk factor and consumption of modest quantity of alcohol is protective, right? So smoking is a risk factor, modest quantity of alcohol, in the sense I would say 2 glasses of wine per week is protective against development of SLE, right? So that means this statement is also false. The last point is epigenetics have no role in SLE. Obviously that is false, because genetics alone cannot explain the risk of developing SLE, right? Many patients with no known identifiable genetic mutations do present with SLE. So this is false, because epigenetics does play an important role. So that makes our option B as the correct answer. Okay. Now moving to the next question. Criteria immunofluorescence is done for which antibody in SLE? Well, the point to note here is that when we talk about ANA, which is the most common and thus the most sensitive antibody in SLA, right? This is most common and thus most sensitive antibody in SLE. This has to be checked with a method called as indirect immunofluorescence. The method for this is indirect immunofluorescence. Okay. And the second point we need to learn is that when we talk about anti-DS DNA, for me the titers of anti-DS DNA are very important, because anti-DS DNA, more than identification of cases of SLE, this is more helpful for me to predict the progression of the disease. Now higher the titer, that means more active is the disease. So this correlates with disease activity, and anti-DS DNA also correlates with risk of, we have already studied this point, it correlates with risk of lupus nephritis or LN, lupus nephritis. Now the method that is used for assessing the anti-DS DNA titers is what we call as criteria immunofluorescence. Criteria immunofluorescence. Okay, so the correct answer here would be option B, anti-DS DNA. Okay, option B is right. There is a small typo, do correct it. It is the criteria immunofluorescence which is used for anti-DS DNA titers. Okay. Now what we had as a next question. A 30-year-old woman who is a known case of SLE presented with complaints of frothiness in urine. Urine examination revealed proteinuria. The doctor suspects lupus nephritis and performs a renal biopsy. It shows presence of wire loop appearance with glomerular proliferation, right? Now the moment question says that we are talking about glomerular proliferation, then it has to be class 3 or class 4 lupus nephritis. Now these two conditions are called as proliferative forms of lupus nephritis. Proliferative forms of LN. Okay. So I have to, whatever choose, I have to choose between these two, class 3 or class 4. Now the pointer here is the presence of wire loop appearance or wire loop lesions. Wire loop lesions are typically seen in class 4 lupus nephritis, right? So here in class 4 lupus nephritis, we see these wire loop lesions. So that's why I'm going ahead with option C. The class 4 is also known as diffuse nephritis. Diffuse nephritis, because the proliferative changes are seen in more than or equal to 50% of glomeruli. That's why we call it as diffuse nephritis. So option C becomes the correct answer for this question, diffuse lupus nephritis. Okay. Now let's move to the next question. Which of the following is false regarding idiopathic pulmonary fibrosis? So we are talking about an ILD. This is a most common type of ILD. Now this ILD is typically seen in elderly males who smoke. So a typical patient of IPF is an elderly smoker male. Okay, now let us look into the option. Affects more men than women. Obviously that's a true statement. Okay. Now, next one. Subepithelial collection of myofibroblasts and collagen is seen in the biopsy. Well, this is a connective tissue disorder where there is increased proliferation of fibroblast depositing more connective tissue. So as of now, this appears true. Anyway, I will revisit this option again. Okay. Now, when I look at option C, lung transplantation is only viable therapeutic option. Lung transplantation is the only viable therapeutic option. Do you think it is true? No, right? How do we treat a case of idiopathic pulmonary fibrosis? The first line management for these patients are going to be anti-fibrotic agents, right? Anti-fibrotic agents. For example, I can quote is nintedanib and pirfenidone. Then if that is not helping and the condition is still progressing, then as second line agents, I can think of using immunosuppressants, right? And when I talk about immunosuppressants, that includes from milder end of the spectrum like the mycophenolate mofetil or your cyclosporine, to much more effective or a stronger immunosuppressants like cyclophosphamide. Okay. If disease relentlessly progresses despite use of immunosuppressant, then as a third line measure, I would think of lung transplantation. Now, if I make a statement saying that lung transplantation is the only viable option, do you think it is true? Obviously no, right? So option C is a false statement. Lung transplantation is a last resort and not the only option available with us. Okay. Last point, carries a poor prognosis with estimated 50% survival of 3 to 5 years. Well, this is also a true statement. Now, when we talk about the the idiopathic pulmonary fibrosis, we have to remember that there are two broad patterns of ILD. One is called as UIP pattern and the other one is called as NSIP pattern. And all those ILDs which have UIP pattern on histopathology and radiology. This is basically a histopathological radiological patternization. And when you take the biopsy or the CT, we can categorize the patient as having either UIP pattern or NSIP pattern. A UIP pattern, the classical example is idiopathic pulmonary fibrosis, the disease about which this question is talking, right? And the NSIP pattern, the classical example would be the connective tissue disorders related ILDs. So there are various ILDs where connective tissue disorders like, for example, scleroderma or SLE is responsible for ILDs. Those will be called as CTD related ILDs. Now, typically in UIP pattern, on the CT scan, the high resolution chest CT, we will see honeycomb changes. That is because of the extensive bronchiectasis. And in patients with the NSIP pattern, we get ground glass opacities. Okay. Now you tell me, when I say extensive bronchiectasis, severe distortion of the lung architecture, making it look like a honeycomb, would have a better prognosis, or something which looks like pneumonia would have a better prognosis? Obviously, something that looks like pneumonia would have a better prognosis, right? So UIP pattern generally carries poor prognosis. And in that case, I can say that IPF carries poor prognosis. On the other hand, NSIP relatively carries good prognosis. It carries better prognosis. So the last statement is also true. So we had to pick up a false statement and option C becomes our false statement. Okay guys, if you are able to hear me loud and clear, just put a comment because I'm unable to see your comments. Okay. Now we have a question on lactic acidosis. Okay. Now what do I mean by lactic acidosis? In simple words, serum lactate is elevated, right, or increased. That is where we call it as lactic acidosis. Okay. Now this lactic acidosis can be because of two reasons. One, normally what happens is if you have tissue hypoxia, then we switch the metabolism from aerobic metabolism to anaerobic metabolism, and lactate is a byproduct of anaerobic metabolism. So elevated lactate can be byproduct of anaerobic metabolism, and that would typically happen when there is hypoxia, right, which is usually secondary to hypoxia. So anything that causes hypoxia can cause lactic acidosis, and if hypoxia is responsible for lactic acidosis, we call it as type A lactic acidosis. Type A lactic acidosis. But there are conditions where in the absence of hypoxia, lactic acid levels can be high because of the abnormalities of either formation of lactic acid or its metabolism, right? So if there is increased lactate production without hypoxia, we would call it as type B lactic acidosis. We call it as type B lactic acidosis. Okay, so now I have given you the background. When do you call it as type A and type B? In this question, they are asking causes for type A lactic acidosis except, right? Now, all you need to do is find out which one is known to cause hypoxia. If it is known to cause hypoxia, it will be responsible for type A lactic acidosis. If it is not known to cause hypoxia, then it will be responsible for type B lactic acidosis, right? Now, severe anemia, we understand that blood's oxygen carrying capacity is reduced, so tissues are getting less oxygen, so tissues are switching to anaerobic metabolism, and that is why there is increased lactic acid production. So this will obviously be type A. Okay. Now in septic shock, what happens? The tissues are not getting adequate blood supply because of the shock. Again, tissues are going into anaerobic metabolism. So this is again a hypoxic type. So this will also be type A. Okay. Now in rhabdomyolysis, typically rhabdomyolysis happens because of the muscular injury. Muscular injury can happen because of hypoxia, right? Tissue hypoxia. And again, I would rather count this as type A. But when it comes to paracetamol toxicity, it is because of the increased production of lactic acid, because at the level of kidneys and the level of liver there is impairment. So predominantly impaired liver function makes you unable to metabolize lactate, and that is why your lactate level is high, and it is not because of the tissue hypoxia, right? So that's why option D becomes the correct answer. See, we all know that paracetamol is a liver toxin, right? It is a hepatotoxin at high doses, and because of the hepatotoxicity there is acute liver failure. So if you guys have gone through my acute liver failure video module, you must know that lactic acid levels are part of the criteria for deciding when to go for liver transplantation in a patient with paracetamol poisoning, right? Okay, so option D is the answer. Option D, paracetamol toxicity, is an example for type B lactic acidosis. Okay, next one, seen in type 2 respiratory failure. Now, what do you mean by type 2 respiratory failure? We have 4 types of respiratory failure. The first one is type 1 respiratory failure. Type 1 respiratory failure is also called as hypoxic respiratory failure. Now, what does that mean? The patient has a problem in oxygenating the blood. He has no issues in eliminating the carbon dioxide. So basically, lungs have two functions. Bring in the oxygen, put it into the blood, and take the carbon dioxide from the blood, throw it into the environment. If they fail to do any one of these, that means you have respiratory failure. In type 1, the pure problem is unable to get the oxygen into your blood. So when you look at the ABG, what you will notice is PaO2 in these patients will be decreased, but because these patients do not have any abnormality of carbon dioxide clearance, PaCO2 would be normal. Okay. Now you should also remember that when PaO2 decreases, you have hypoxia, right? Now, do you think your body will just keep quiet? My saturation is dropping, I will tolerate it and be just like that? Obviously no, right? So your body try to compensate by increasing the respiratory rate. Whenever we have hypoxia, we have increased respiratory rate, right? Tachypnea. And that tachypnea makes sure that you also lose a lot of carbon dioxide. So many times patients with hypoxic or type 1 respiratory failure may have the PaCO2 which is lower than normal. Fair. As long as your PaCO2 is not high, that would be counted as type 1 respiratory failure. But any patient who has type 2 respiratory failure, he will have high PaCO2. So we call that as hypercapnic or hypercarbic respiratory failure. So here the PaCO2 will be high. It doesn't matter what is happening with oxygen. As long as PaCO2 is high, it will be counted as type 2. So even if PaO2 is low, normal, increased, all of that will be counted as hypercapnic respiratory failure. So here the principal abnormality is that you are unable to clear the carbon dioxide from your blood. Okay. So if I do an ABG of a patient with type 2 respiratory failure, what do I expect to see? Elevated PaCO2. Now what is the normal range of PaCO2? The normal range of PaCO2 is in the range of 35 to 45 millimeters of mercury. So obviously to call it as elevated, it should be more than 45 millimeters of mercury, making option B as the answer. Okay. Now before I move to next question, let me give you a ABG picture as an exercise. All you need to do is tell me whether this particular patient has got a type 1 or type 2 respiratory failure. Okay. So his PO2 is 100 millimeters of mercury. Okay, let me make it a bit more complex. His PO2 is 50 millimeters of mercury and his PaCO2 is 110 millimeters of mercury. And the question is, which type of respiratory failure? Which type of respiratory failure it is, right? Is it type 1 or type 2? So whenever you get a question of detecting the type of respiratory failure, all you need to do is first look at the PaCO2. PaCO2 high, then label it as type 2 respiratory failure. If PaCO2 is not high, that means either it is normal or low, then look at the oxygen. If oxygen is low, then it is type 1. Now you might ask me, sir, what if the oxygen and carbon dioxide both are normal? Then it is a normal ABG, there is no respiratory failure, right? Okay. Now we are moving to the next question. There's a small correction here. If you have already solved the question, then you may be confused with this because unfortunately this ABG lacked the information about the chloride. So let me give you the value. Okay, so the chloride for this patient is 90 millimoles per liter. Okay, so that is the chloride value. Now what are they asking? Identify whether this is high anion gap metabolic acidosis, normal anion gap metabolic acidosis, or respiratory acidosis, or respiratory alkalosis. Okay. Now I will give you a simple approach to ABG. Every time you deal with a case of ABG, first thing you should look at is the pH. Right. Now pH can be normal. Now what is the normal range of pH? That is 7.35 to 7.45. Now it can be lesser than this. If it is less than 7.35, we can clearly call it as acidosis. And if it is more than 7.45, we can clearly call it as alkalosis. The values in between is what we call as normal. But please remember, even if the pH is normal, it need not mean that there is no acid-base abnormality. Even with a normal pH, you can have acid-base abnormality. Let me give you an example, right? Okay, so I'm giving you an example ABG. So here pH is 7.38. PCO2 is 80 millimeters of mercury and bicarb is, let me say, 10 millimoles per liter. Do you think it is a normal ABG? If you only look at pH appears to be in the normal range. So you might say, oh sir, I got a normal ABG. No, but when you look at PaCO2 and the bicarb, both are abnormal, right? Both are abnormal. Now that makes it an abnormal ABG. So please remember, a normal pH does not rule out an acid-base disorder. Now, what do I call if the pH is normal? That is where I'll come to, right? So, if pH is normal, there are two possibilities. The first possibility is no ABG abnormality. Well, that's a possibility, but I will call it as no ABG abnormality only when all the components of the ABG, that means pH, PaCO2 and bicarb are normal. If any one of them is abnormal, it is not a normal ABG. In that case, what it can be? It can be what we call as fully compensated ABG abnormality, whatever it is, whether it is acidosis, alkalosis, whether it is metabolic, whether it is respiratory, it is fully compensated when the pH is back to the normal range. So basically what happens is, we have in our body some amount of acids, some amount of bases, right? Now our pH of the blood needs to be perfectly maintained in this range to maintain all the metabolic activity. If pH is more than this, or especially when it is less than this, acidosis is not well tolerated by human body. Now to maintain this pH, we have to have a balance between acids and bases. Now what is the major acid in human body? The major acid actually comes from our carbon dioxide. Carbon dioxide, when dissolved with water, becomes what we call as carbonic acid. So carbonic acid is our major acid. Okay, and what is our major base? Our major base is bicarbonate, right? HCO3 minus. So HCO3 minus is base. And can I say carbon dioxide as a source of acid? So basically it is indicating acid. Now if I have to maintain a perfect pH in the range of 7.3 to 7.45, our body can only play with these two substances. Okay, suppose if someone has taken salicylic acid, which is acid, so he has added too much acid, right? Now what should I do? If I add too much acid, what should I do to the base? I should increase the base so that pH remains balanced. How body will play with that? Number one, body can play with carbon dioxide through your respiratory system, and body can play with the base or bicarbonate with your kidneys. Kidneys can decide the amount of bicarbonate that it will eliminate, right? If you need more base, kidney will conserve more bicarbonate and eliminate less bicarbonate, right? And if you need to add more acids to body, then lungs will retain more carbon dioxide. And if you need to remove more acids from the body, lungs will throw out carbon dioxide. Okay, now I will ask you a question. I have a patient with very low bicarbonate. Now what do you expect the lungs to do? See, when I say low bicarbonate, that means the base is low, right? The base in the body is decreased. So base is decreasing, proportionate decrease in the acid should happen. So the lungs, as a compensatory mechanism, should bring down the carbonic acid by eliminating more carbon dioxide. The vice versa is also true, right? For example, if my lungs have failed to eliminate carbon dioxide, I am building up too much of acid in the body. Now to compensate for that, I need more quantity of base. So there should be increased retention of bicarbonate by the kidneys. So can I say that the direction of movement of the compensatory mechanism is same as the direction of movement of the primary abnormality? Here the primary abnormality was deficit in the base, so we had a decrease in carbon dioxide, right? So in the second example, there was too much carbon dioxide retention, and to compensate for that, we had to retain bicarbonate. So the direction of compensation and primary abnormality will always be same. Okay, so I hope you have understood these points. Now let us look at how do we approach ABG. You might have had your own set of mnemonics to recognize the ABG abnormalities, but a simple approach would be to look at the pH and PaCO2. Okay, now first thing is pH, that will help us to distinguish between acidosis and alkalosis, and if it is fully compensated, where the compensatory mechanisms have brought the pH back to normal range from whatever it was, in that case we use 7.4 as the cutoff. If it is less than 7.4 after the compensation, then it is acidosis. If it is more than 7.4, it is alkalosis. This rule you will apply only when pH is within the normal range and you have abnormalities of carbon dioxide and bicarbonate. Okay, clear? Otherwise, when pH is clearly out of range, you know how to categorize them into acidosis, alkalosis. Once I categorize them into acidosis and alkalosis, all I need to do is look at the direction of movement of pH and PaCO2. Okay. Now, if the pH is decreasing, and PaCO2 is decreasing, or if the pH is increasing and PaCO2 are increasing, in both those conditions the problem has to be metabolic. And if you notice that pH and PaCO2 are following the opposite direction, in the sense when pH is decreasing and PaCO2 is increasing, or when pH is increasing the PaCO2 is decreasing, they are following the opposite direction. pH is either increasing and PaCO2 is decreasing, they are not following the same direction, then it is usually a respiratory abnormality. You can remember this with the mnemonic ROMS. ROMS stands for respiratory opposite, pH and PaCO2 following the opposite direction, and MS stands for metabolic same. Metabolic same. So metabolic in the same direction. Clear? Okay. Now once you have got to know whether it is metabolic acidosis or alkalosis or respiratory acidosis or alkalosis, your first level of ABG dissection is done. But if it is a case of metabolic acidosis, we need to go further, right? Most important thing will be we need to calculate the anion graph. Now first we will go back to the ABG and address what kind of ABG abnormality it is. Now pH is 7.183. It is definitely less than 7.35. So that makes it a condition as acidosis. Now once I have acidosis, that means pH has decreased, I will look at the PaCO2. The PaCO2 here is 44.9 millimeters of mercury, right? Almost the border end of normalcy, right? Border end of the normalcy. Is it more than the normal range? No, right? So I would take this PaCO2 as not increased but decreased. Only when it is more than 50 millimeters of mercury, I would take it as increased. So now that means that I have pH and PaCO2 both going in the same direction, right? So in that case, what should I count this as? I will count this as metabolic acidosis. Metabolic because they are in the same direction, acidosis because pH is less than 7.35. Now if it is a case of metabolic acidosis, we need to also calculate the anion gap, right? So if it is metabolic acidosis, we have to calculate the anion gap. Now what is the formula for anion gap? Anion gap is basically the difference between the measurable cations and measurable anions. Now what do I mean by cations? Those ions which carry a positive charge on them are cations. Those ions which carry a negative charge on them are anions. Now in human body, you will have a perfect balance of cations and anions. You don't have more cations and less anions, or vice versa is not known to happen. Okay. So just to give you an example, let me say that this is a compartment or a human body. Here we have some amount of perfect amount of anions and cations. So let me say both of them have 100 molecules of cations, 100 molecules of anion. Now the major cation in human body is going to be sodium. Okay. Now other cations are like potassium, calcium, but they are very small in number. So we will give more weightage to sodium, right? Just to give you hypothetical number, I am repeating again, it is a hypothetical number. Let me say that this 70% of cation molecules in this compartment are sodium, right? And then remaining 30% are unmeasurable cations. Unmeasurable cations. Okay, so 70% sodium, 30% unmeasurable cations. Just a hypothetical example. Now I will also have 100 anions. Among the anions, right, let me say around 60 anions are going to be my chloride molecules, right? And around 5 anions, just to give you again a hypothetical number, are going to be my bicarbonate ions. So in that case, here I have 35 molecules which are unmeasurable, right? Now in both the systems 1 and system 2, we have equal amount of ions, right? Cations are 100, anions are 100. But when I check them or when I do tests, I will mostly test sodium and I will mostly test chloride and bicarbonate. Now if I do that, right, my chloride plus bicarbonate would be 65, and when I check sodium it is going to be 70, right? Now if I see the difference between the measured anions and cations, I will get a difference of 5. This is what we call as anion gap. Okay. Anion gap is basically the difference between measured cations and anions. That does not mean that our body has a difference between the amount of anions and cations. Now think of a hypothetical scenario where from an external source I add anions. To give you an example, lactic acid is an anion, right? Now if I add lactic acid, what ABG abnormality I will develop? I will develop acidosis for sure, right? Metabolic acidosis, because I am adding lactic acid. Now let me say that I am adding 10 molecules of lactic acid, right? 10 molecules of lactic acid. Now body has to maintain an electric neutrality, right? There can't be 110 anions and 100 cations. The problem is if there is excess charge, basically there is a potential difference and it becomes a flowing electricity. That doesn't happen in nature, right? So now what should I do if I have added 10 lactic acid molecules? That has to be compensated by decreasing the chloride and bicarbonate molecules. That is how body has to compensate, right? So let me just to again give you a hypothetical number. I have to subtract 10 from bicarb and chloride. So let me say that chloride becomes from 60, it becomes 50, 53, 7 minus from chloride, and bicarbonate from 5 becomes 2, right? 3 minus from here. Okay. Now I have 55 plus 10, 65 plus 35, 100 anion molecules. I have 100 cation molecules. But now what happens to the anion gap if I check? Anion gap will be sodium minus chloride and bicarbonate. So this is 55. 70 minus 55, now it became 15. Earlier it was 5. Now what happened to the anion gap? It increased. Now what does that indicate? It simply indicates that we have added an unmeasurable acid anion to the system. Basically, this anion gap helps us to identify those cases of metabolic acidosis where there is an addition of unmeasurable acid anion. Okay. So now how do we calculate that? Anion gap is defined as sodium, which is representing our measurable cations, minus chloride plus bicarbonate, which is representing my unmeasurable measurable cations, right? Now let us apply this formula here. The sodium is given in this ABG, which is 135, okay, minus chloride and bicarbonate, right? Chloride I have given you the number which was not there in the question as 90, and bicarbonate here will be given in the question as 16.9. So let me make it as 17. 90 plus 17. So I will have 90 plus 17. Okay. Now 135 minus 90 plus 17 will be 135 minus 117, right? Correct me if I'm wrong. So that brings the answer to be 18. So the anion gap here is 18. The normal anion gap is less than 8, right? When it is more than 8, it means you have high anion gap metabolic acidosis. High anion gap metabolic acidosis. Now you might also come across formulas where potassium is also included as a cation, because that is also a measured value. If you are adding potassium into the formula, we have to bring in 4 additional points here, right? So in that case, if you are using the formula for potassium, then when anion gap is more than 12, we will call it as high anion gap metabolic acidosis. So here clearly it is a case of high anion gap metabolic acidosis, making option A as the answer, right? So any ABG, first decide whether it is normal or abnormal. If it is abnormal, decide whether it is acidosis or alkalosis looking at the pH. And after that, decide whether it is metabolic or respiratory by applying the mnemonic ROMs. Once we have done that, if it is a case of metabolic acidosis, also calculate the anion gap. Okay. And you have to be familiar with those conditions where high anion gap metabolic acidosis happens and where normal anion gap metabolic acidosis happens. Okay. We are moving to the next disease. Which of the following is not true about Whipple's disease? Okay. Now, Whipple's disease is a infective enteropathy, where patient present with malabsorption syndromes, right? And it is typically caused by an organism called as Troperima whippli. So this is a true statement. Okay. Now, because this is an infective condition, obviously we would be treating them with antibiotics. Generally, what we do is initial 1 to 2 weeks we treat them with meropenem. Maybe then we can step down to ceftriaxone. Otherwise, meropenem is a best drug when it comes to Troperima whippli infection. But ceftriaxone is also part of the treatment regimen. So statement B is also true. Okay. Now statement C is false. I'll tell you why. Pass positive macrophages in the right clinical context are highly specific for the Whipple's disease, but you can also get pass positive macrophages in conditions like leishmaniasis. You may be getting more examples in your pathology textbooks, but I'm giving you one, right? So can I say that they're absolutely specific for the Whipple's disease? No. In clinical practice, when we have the right context, see, we know leishmaniasis is going to present differently and Whipple's disease is going to present differently. So as a clinician, if my intestinal biopsy says that, okay, there are pass positive macrophages present on the biopsy, I would make the diagnosis of Whipple's disease. But if I make a statement saying that they're highly specific, it is going to be false statement, right? So this is a false statement. Okay, then you might ask me, sir, what is the most specific test for diagnosis of Whipple's disease? The most specific test for diagnosis of Whipple's disease is the biopsy specimen subjected to PCR for Troperima whippli. So if the PCR is positive for Troperima whippli, then it is highly specific, because PCR cannot recognize like PCR says T whippli means it is T whippli, it can't be leishmania. But if the biopsy says pass positive macrophages, it can be leishmaniasis and so many other conditions. Okay. Now the last point, dementia is a poor prognostic sign. Well, do you remember, if you have watched the video on Whipple's disease, I had a video of a patient who had this thing called as oculomasticatory myarrhythmia, where his eyeball movements were synchronized with their masticatory muscle contraction, right? Every time he moves eyeballs, he was also contracting the muscles of mastication, which is called as oculomasticatory myarrhythmia. So Whipple's disease is not only affecting your gut, but it is also affecting your brain, and dementia is very common. In fact, most of the patients with Whipple's disease die because of the neurological dysfunction and not because of the gut problem. So this is certainly a true statement. Dementia, if present, is a poor prognostic sign. Okay. So that becomes our answer. Option D becomes the answer. Sorry, option C becomes the answer. Dementia is true. Okay. Next. Not regarding resuscitation of a patient in septic shock, right? Not true regarding resuscitation of a patient in sepsis or septic shock. Now, generally, when we have a patient with sepsis, we manage them based on the guidelines issued by what is called as Surviving Sepsis Campaign, SSC, Surviving Sepsis Campaign guidelines. Okay, they are updated once in 5 years. So according to the latest guidelines, right, let us see if these statements make sense. Resuscitation with IV crystalloid should begin in the first 3 hours, preferably as soon as possible, right? No delay anticipated or acceptable, but if possible, if very challenging, at least within 3 hours, we should start giving the patient crystalloids, right? What are crystalloids? Like your normal saline, dextrose normal saline, ringer lactate, these are all considered as crystalloids. They are isotonic to your plasma and they do not contain any high molecular weight substance. They are the ones which are preferred for resuscitating once the patient has gone into septic shock or is in sepsis. Now, if I need to use inotropes, noradrenaline or norepinephrine is the first choice vasopressor. Okay, what else can be used? We can use as a second choice, we can think of using adrenaline and vasopressin. Adrenaline and vasopressin. What is recommended is don't use dopamine, and dobutamine doesn't find a specific role here, right? So we have to avoid dopamine. Why should we avoid dopamine in a patient with septic shock? The reason is dopamine is a very strong inotropic agent, but also strong chronotropic agent. Now, what do I mean by chronotropy? Increasing the heart rate. See, now think about a patient who is in septic shock. His heart rate is already high. And because of the high heart rate, his diastole has become shortened. And because of the shortening of diastole, there is no sufficient time for the left ventricle to fill. So if left ventricle is not filling well, obviously its ejection and stroke volume will also be less, right? And this diastolic dysfunction also starts affecting the coronary blood flow, because coronaries receive blood supply during diastole. During systole, these coronaries are embedded in your myocardium. So when myocardial cells contract, they compress the coronaries. So there is not much of systolic flow happening through coronaries. So myocardium is not getting good amount of blood during coronaries. Whatever it gets during diastole. Right? If I make the diastole shorter, then there will be lesser quantity of blood supplied to the heart itself, and that makes heart to go dysfunctional more and more. Right? So any drug that has a profound impact on heart rate is not acceptable, at least in patients with shock. I can use dopamine when I am dealing with cases of heart blocks, because where I want a higher heart rate, but not here, right? Okay. So second statement is true. First statement is true. Second statement is also true. Okay, now the third one, dobutamine should be used with the intent of reducing norepinephrine dose. This is false. See, preferably we don't use dobutamine. The indication for using dobutamine is mainly the cardiogenic shock, not for patient with septic shock. It is for cardiogenic shock. It is indicated for cardiogenic shock patient. So that gives me the false statement, and I guess that would be my correct answer. Anyway, let us also look at the option D. Option D says hydroxyethyl starches and gelatins are not recommended. That is true, right? Both of these, hydroxyethyl starch or HES and gelatins, these are colloids, right? Colloids are basically plasma expanders. They carry high molecular weight, and I have told you repeatedly, what we recommend is use of crystalloids and not colloids. Use of colloids brings in its own set of side effects. There is increased risk of renal dysfunction, and there is also increased risk of bleeding when we use colloids. So they are not recommended anymore, right? So we are going ahead with option C as the right statement. Okay. Next, a patient presented in the OPD with hemoglobin of 4 along with the following finding. What could be the possible cause, right? So this is a straightforward question. What do we see here is 𝐒𝐿, and 𝐒𝐿 is typical of the iron deficiency anemia, right? So it starts with what we call as flattening of the nails, platyonychia, and as the condition progresses, it progresses to become 𝐒𝐿 or spooning of nails, and that is a typical story of iron deficiency anemia, and that becomes a correct answer. Now, next question. The diagnostic criteria for hemophagocytic lymphohistiocytosis. HLH stands for hemophagocytic lymphohistiocytosis. Okay. Now, what is happening in these conditions? There is hyperactive histiocytes, phagocytic histiocytes, which are causing organ damage, right? So here, most commonly affected organ is going to be liver. Okay. Now there are some set of diagnostic criteria. Currently we follow 2004 and 2009 criteria for diagnosis of HLH. And one thing which is very important for recognition of HLH is in any patient who has symptoms of fever, splenomegaly, and liver dysfunction is to test for their fibrinogen levels. So please remember that in hemophagocytic lymphohistiocytosis, you will have not raised fibrinogen level, but rather hypofibrinogenemia. You will have hypofibrinogenemia. So if I have fibrin levels which are very low, that favors the diagnosis of hemophagocytic lymphohistiocytosis and not the raised fibrinogen levels. Okay. Now ferritin, yes, it is an acute phase reactant. In any acute illness, it may be elevated, and so is the case of HLH. Apart from that, you will have splenomegaly, you can have hepatomegaly, okay, you can have thrombocytopenias, okay, and fever is the most common complaint. Many a times this HLH happens as a secondary or complications to infections. In the recent times, as a practicing physician, I've seen plenty of dengue patients going on to develop hemophagocytic lymphohistiocytosis. So first they present as dengue, the platelet count is improving, they seem like settling down and they're ready for discharge. And then we start noticing that the platelet count which was showing improvement is dropping down again, their liver function test is going for a toss. I suspect the possibility of hemophagocytic lymphohistiocytosis because that is not the natural course of dengue. Natural course of dengue is once the platelet count starts rising, hematocrit starts improving, there is generally a road to recovery, right? Okay. Now for further confirmation, I would check for the serum ferritin levels and fibrinogen levels. When I get hypofibrinogenemia, then I start believing that I'm dealing with a case of HLH. Okay. Now, below what minimum level of transferrin saturation hemoglobin synthesis become impaired, that all of us know, when the transferrin saturation. Now, what is this transferrin? Transferrin is a iron transport molecule, right? Now, at any given point of time in normal physiology, 1/3 of transferrin that is available is saturated or it is bound by iron, saturated with iron, and 2/3 of it is unsaturated. This is the normal iron balance when you are getting adequate iron. Okay. Now, if I have iron deficiency, the first thing is that the amount of transferrin that is circulating with the bound iron will become less. Simple. See, I take food, it contains iron, the iron is absorbed in my intestine, the site of absorption is duodenum, and from there this iron has to reach liver and from there eventually to your bone marrow for your RBC production. Okay, whatever iron that is required by bone marrow will be given to bone marrow, excess iron will be stored in the liver in the form of ferritin, right? So there are 2 points to note here. The transferrin is the transport form of iron, transporter of iron, and ferritin is a storage form of iron. Storage form of iron. Okay. Now the point here is, if I have low iron, then low iron is absorbed from the gut. So lower amount of iron will be circulating bound to transferrin, right? So whenever your iron levels start decreasing, the amount of iron bound to circulating transferrin molecules will also be low, right? So typically when it is less than 15 to 20%, the erythropoiesis and hemoglobin synthesis or metabolism becomes impaired. So option A becomes the sensible answer here. Okay. Next one. Which of the following is not true about transferrin? We were just talking about transferrin. It is a transport molecule for iron. It is usually detected by immunoassay. This can distinguish between iron deficiency anemia and anemia of chronic disease. I'll come to that point. It is reduced in iron deficiency anemia. Well, transferrin saturation can be reduced in iron deficiency anemia, as we already know. And the normal range is 4 to 9 micrograms per liter. Okay. So point to note here is normal range, that is true. Okay. And then it can help us to distinguish between the iron deficiency anemia and anemia of chronic disease, because see, as I've already told you, when you look at transferrin, in a normal condition, normalcy, 1/3 is saturated and 2/3 is unsaturated. That means it is not bound by iron, right? So if there is a term called as TIBC. Now what is this TIBC? TIBC is the total iron binding capacity, right? It is basically the amount of iron that can be bound to transferrin. If it is more saturated, it can bind less because it is already saturated, right? Let me say 50% of transferrin molecules are bound by iron, then there is only 50% possibility of, like, only remaining 50% molecules can bind the iron, right? Okay. So now if I have a condition where there is iron deficiency, then less amount of iron is saturated with the transferrin and there is availability of the unbound molecules for binding. So can I say that TIBC is increased in patients with the iron deficiency anemia? Yes, right? But in patients with the chronic diseases, the TIBC is not increased, right? So that point helps you to distinguish between the anemia of chronic disease and iron deficiency anemia. So indirectly I can say that the transferrin helps us to distinguish between the iron deficiency anemia and anemia of chronic disease. That is also true, right? Now transferrin is reduced in iron deficiency anemia is false. Why? We are talking about transferrin, right? Transferrin saturation is reduced in iron deficiency anemia. This is a protein. The protein synthesis is not reduced in iron deficiency anemia, and that's why option C becomes the false statement, and that would be my answer. Okay, next, in iron tolerance test, how much iron increase in serum iron is seen in case of normal iron absorption? Right, now why do we do this ITT or iron tolerance test? We mainly do this to assess the absorbing capability of the patient's intestine. See, nowadays there are a lot of conditions where iron absorption doesn't happen properly. A classical example I can give you is celiac disease. Now, celiac disease is a disease which predominantly affects the duodenum, right? Now, duodenum is the site of iron absorption, right? Celiac disease affects the duodenum, and that is the site of iron absorption. Now, for such a patient, if I give iron, it will not be well absorbed because their duodenum is inflamed, right? Patient will present with iron deficiency anemia, and no matter how much oral iron I keep giving, his duodenum is not helping in the absorption, and his blood iron levels will not increase, and thus the anemia will not increase. And that is why, in fact, celiac disease is right now a very important cause for iron deficiency anemia. Causes iron deficiency anemia that is refractory to oral iron replacement. Refractory to oral iron replacement, because absorption is not happening, right? But the same patient will respond beautifully the moment I give them iron injection, because here the problem is not the utilization of the iron, it is the absorption of iron, right? Now, why should I waste my few months of patient time trying to give the oral iron and then get to know later that okay, there was no absorption because he had maybe celiac disease or something else, and the hemoglobin has not improved and it is further dropped. Instead, what I can do is I can do this iron tolerance test. So what we do in iron tolerance test is we give 2 doses of oral iron tablets, and we will check the serum iron levels over next 2 to 3 hours, right? So we give 2 standard doses of oral iron preparation, and then we will check serum iron levels 2 to 3 hours later. Okay, now this serum iron level in normal condition, we would have checked the serum iron level before giving the tablets also, please remember that. So in normalcy, there will be more than 100 micrograms per liter increase in serum iron level happens if the absorptive surface is normal. Okay, if there is impaired absorption, well, I will not see 100 microgram rise in the serum iron levels, right? It may be rising by 10, 20, 30 or no rise. That tells me that patient is not having a good absorptive surface. Such patient, even if they have iron deficiency anemia, they are unlikely to be benefited by oral iron. We have to give them parenteral iron. Clear? Okay, so that makes option D as the right answer for this question. Okay, next. So we will proceed with the next question. This question is pretty straightforward. You are experts on this question than me, right? The question is simple. They have given a histopath image, basically a microscopy or a peripheral smear image, and they are asking what could be the cause for this anemia. In this image, we can see a lymphocyte, and when we compare the RBCs in comparison to lymphocytes, the RBCs are smaller, right? They are definitely smaller. So what we have here is a microcytic hypochromic anemia. Microcytic hypochromic anemia. So if we have microcytic hypochromic anemia, what could be the answer here, right? Obviously it is iron deficiency anemia. Folate and B12 cause what we know as macrocytic anemia. So option C would be the right answer. Okay, next. What is the function of erythroferrone? Well, I'm sure many of you are not familiar with this thing called as erythroferrone, right? What is erythroferrone? Normally what happens is, this is something to do with iron metabolism that we can understand the moment I say erythroferrone. Erythro, you know, we're talking about iron. Okay, what is erythroferrone? Normally when we take iron from the gut, right? So let me say oral iron, it may be in the form of supplement or in the form of diet. Now that through our oropharynx, right, oral route, it will enter where? It will come to the duodenum, that is the site of absorption. The site of absorption of iron is going to be duodenum. Okay, now in the duodenum, this iron gets absorbed. Once it is absorbed, it is then transferred to liver. Now the transport form is going to be what we call as transferrin, right? It is transported bound to transferrin. And once it reaches the liver, this iron will be stored there in the form of ferritin. Ferritin is our storage form. But we also know that excess iron is toxic or problematic to patients, right? We have this condition called as hemochromatosis, where organs get damaged because of the excess iron stored. Iron is toxic. It is a reactive oxygen species. Okay. So in that case, body has to regulate the amount of iron that we absorb from the diet. If I absorb more iron, it can be problematic, right? And if I absorb less iron, again, our erythropoiesis won't happen properly. So there has to be a regulator for this iron absorption, and that regulator is what we call as hepcidin, right? Hepcidin is called as the master regulator of iron metabolism. Master regulator of iron metabolism. Okay. Now what this hepcidin does is, hepcidin negatively influences the iron absorption at the level of duodenum. Duodenum, we have a molecule called as ferroportin. Ferroportin, it inhibits the ferroportin, and ferroportin is responsible for the iron trafficking into the cells. So if I inhibit ferroportin, then I will not absorb the iron. Okay. But we might have, or we might need some regulation even above the hepcidin, and that regulation comes from erythroferrone. So what erythroferrone does is, erythroferrone is produced by your erythroblasts. It is produced by erythroblast, and it suppresses hepcidin. Now if I am suppressing hepcidin, then I am removing the suppression from ferroportin, and I can increase the iron absorption. So erythroferrone increases iron absorption by inhibiting hepcidin production, right? By inhibiting hepcidin production. So if they ask you what is the mechanism of erythroferrone, now we know the mechanism. The mechanism is, it is a suppressor of hepcidin production. Clear? So what becomes the correct answer here? Option B becomes the correct answer. Okay, now let's move to the next one. Which of the following is affected in the stage of negative iron balance? Okay, now when we talk about the iron metabolism, what we know is that first stage of iron deficiency is what we call as negative iron balance. Now at this point of time, in the stage of negative iron balance, mostly what happens is you have lesser quantity of iron than you need. Okay, but not so low that your ferritin stores are depleted, right? So basically what happens is your transferrin saturation starts decreasing, right? And if the transferrin saturation is decreasing, what will happen to the total iron binding capacity? The total iron binding capacity will be increasing, because there, like what would I say? The transferrin saturation represents the amount of transferrin which is bound to iron molecules, and the total iron binding capacity basically represents the amount of free transferrin which is ready to bind the iron molecules. Okay. Now that drop in transferrin saturation that happens may not be perceptible, right? Generally in negative iron balance, the transferrin saturation will be in the range of 15 to 20%. Generally when it is less than 15%, it leads to perceptible changes. But we can clearly notice a rise in total iron binding capacity going more than 360. And that is why if I have to choose between transferrin saturation and total iron binding capacity, I would choose the total iron binding capacity. So TIBC is increase in TIBC with very modest or minimal decrease in transferrin saturation and no anemia. This is the typical negative iron balance stage. Okay. Now from there we progress to impaired erythropoiesis and eventually we develop the microcytic hypochronic anemia. So when iron deficiency happens, the microcytic hypochromic anemia is the end of the spectrum. Before that, we will mainly have the negative iron balance, then impaired erythropoiesis, and then finally anemia. Okay, so option A becomes the right answer here. Now the given test was performed in a patient disorder for which of these tests is used, right? So basically what are they looking for? They are looking for the pallor, right? So the test that they're doing is for pallor, and obviously we do pallor test for anemia. Simple. But many times the simple questions we end up giving wrong answers, and that's why we had included this question. We should keep our feet grounded. We should be able to start from the very basics whenever we deal with questions, right? Like I can give you an example. There was a question on which of the following cells secrete insulin. This question was there in NEET SS, NEET super specialty. Answers were alpha cells, beta cells, gamma cells, something like that. Many students answered it wrong. Those who have completed MD medicine and practicing, even those who are actively practicing diabetes, answered it wrong. Simple reason is overthinking. Like, if they're asking such question, maybe there is some new research, maybe there are some new papers, and that is why at NEET SS level they're asking a question. Like overthinking leads to wrong answers. So keep yourself grounded. Okay. Next. Which of the following is seen last in iron deficiency anemia? A couple of minutes back I was talking about it, right? A full-fledged anemia is the last manifestation of iron deficiency. It starts with the negative iron balance. So option D would be the option C would be the correct answer, right? Okay. Next. A 45-year-old male patient presents with malaise and body ache since 5 days. Routine investigation shows unconjugated hyperbilirubinemia, normal liver enzymes, and his urine contains urobilinogen. Which of the following is not the cause for it? Right? This is very simple question. See, now when we deal with a case of jaundice, all you need to see is whether it is isolated jaundice. That means only jaundice is there, no other LFT abnormality, or whether there is jaundice plus elevated liver enzymes, right? Elevated liver enzymes means SGOT, SGPT, which is nothing but your ALT, AST, and your alk-phos. Okay. Now, if you have a condition where you have impaired liver enzyme plus jaundice, then you have an structural or functional liver disorder. Okay, so you may be having viral hepatitis, you may be having cirrhosis, plenty of causes come into picture, autoimmune hepatitis, alcoholic hepatitis, non-alcoholic steatohepatitis. But if you have isolated jaundice, it is mostly inherited hyperbilirubinemia. All your Dubin-Johnson, Rotor syndrome, inherited hyperbilirubinemia. Okay. Now, how do I differentiate whether it is Crigler-Najjar, Gilbert, or whether it is Dubin-Johnson? Simple. All you need to see is what is the predominant bilirubin here, right? Whether it is conjugated or whether it is unconjugated hyperbilirubinemia. Okay. And if it is conjugated, okay, conjugated, that means you have what you call as direct hyperbilirubinemia. In that case, you have to think of two conditions which can be inherited hyperbilirubinemia conditions, right? What are those? One of them is Dubin-Johnson and the second one is Rotor. It is very easy to remember, right? When I say direct, right, in my direct I have a D and R. These are the syllables where we put emphasis. Direct. D for Dubin-Johnson, R for Rotor. Simple, right? Okay. Now, what conditions can cause unconjugated? When you say unconjugated, we mean indirect hyperbilirubinemia, right? Indirect. Now, simple mnemonic that you can use to remember this is computer generated imagery or CGI, right? Nowadays, all movies, everything is computer generated imagery or CGI. That is a mnemonic. Now, C here stands for Krigler-Najar. G here stands for Gilbert. Okay, and I here stands for indirect hyperbilirubinemia. Indirect hyperbilirubinemia. Simple. CGI, Krigler-Najar, indirect, direct, Dubin-Johnson, and Rotor. Right. So now in this case, what they have mentioned is the patient has got unconjugated bilirubinemia. Unconjugated means indirect. Unconjugated means we have the direct hyperbilirubinemia. Okay. So in that case, what becomes my answer? Gilbert and Krigler-Najar are indirect. Indirect hyperbilirubinemia, and Dubin-Johnson syndrome is direct hyperbilirubinemia, right? Hemolytic anemia will have LFT abnormalities. Okay, so just a small correction. I exchange the terms conjugated and unconjugated. Direct is unconjugated and indirect is conjugated. Okay. Now, next question. A 46-year-old male patient has presented with complaints of pain in the right upper abdomen, malaise and mild fever since 15 days. Investigation shows HBsAg, which is positive, right? The moment I say that HBsAg is positive, it means we are dealing with a case of HBV infection is present. We are not talking about the past infection here, right? We are not talking about the future infection. Right now, patient has infection the moment you say HBsAg is positive. C has HCV negative, right? So now whatever I have is an HBsAg positive case. Now question is asking what should be the next confirmatory test to be done. Okay, the framing of question is not fully acceptable to me because they're saying what is the next confirmatory test. Ideally, the question should be what is the next step. The next step is to look at the anti-HBC IgM. Right? Why I'm interested in anti-HBC IgM? The moment you say HBsAg is positive, that means there is an active hepatitis B infection. I need to know whether this is an acute, recently acquired infection or whether it is a long-standing infection. The best distinguishing test would be to do for the anti-HBC, IgM and IgG, right? So if HBsAg is positive, that means there is infection present, right? And then I will be looking at the anti-HBC, IgM. If that is positive, that means it is a classical case of acute infection. Acute infection. Okay. Now, if anti-HBC IgM is negative, doesn't matter what is happening with IgG. In both the cases, it doesn't matter what is happening with IgG. If HBsAg is positive and anti-HBC IgM is negative, we are dealing with the chronic infection. This was not acquired in the recent time. Now, why that is important? Because we know that most patients of acute hepatitis B virus infection in adults will seroconvert to normalcy. They will not become chronic carriers or chronic hepatitis B cases, right? So 95% of acute hepatitis B virus infections, they revert to normalcy, right? That is why knowing whether this is an acute infection or chronic infection matters. Okay. So here option B would be the right answer. I need to know anti-HBC IgM antibody status to know whether it is acute or chronic. Okay, next. Which of the following statement is false? Shailakumari Yadav, I was in the flow, I missed it. Yeah. Okay. Now, which of the following statement is false regarding hepatitis B? The simple thing is yes. Okay. Which of the following statement is false regarding hepatitis E? Common extrahepatic manifestations include arthritis and pancreatitis. Hepatitis E, yes, it is a known cause for acute hepatitis, right? It is generally not known to cause chronic hepatitis until and unless someone is having the immunocompromised state, right? It is the typical example for acute hepatitis. Hepatitis A and E, only acute, rarely ever chronic. B and C, chronicity possible Now in terms of the risk of chronicity, C carries a higher risk than B. Okay. Now let us look at the statements. They are asking false. Common extrahepatic manifestations include arthritis and pancreatitis. Most of the viral hepatitis come with arthritis. They have a risk of milder degree of pancreatitis. Okay, so I wouldn't count that as false. In endemic regions, see, remember India is endemic. In India, hepatitis E is much more common than hepatitis A. The mortality rate is high, especially in pregnant women. This is true. The first statement is true. Now please remember that typically deaths happen in the last trimester. Last trimester is a very high risk time for the patient to have hepatitis E infection. Okay, next. Improved hygiene reduces the risk of hepatitis E virus infection because the route of spread is fecal-oral, not through the blood or infected syringes, fecal-oral route, and any fecal-oral route infection, obviously the risk would depend on the hygiene status, right? So patients, the societies where there is low socioeconomic status or poor hygiene, there hepatitis E can wreak havoc as an epidemic. So this is also a true statement. Abhinav, you want me to talk about the hepatitis B antibodies? Okay, I'll do that. Okay, 10% of cases may be converted to chronic hepatitis in 5 years. This is absolutely false, right? As we know, whenever you think of A and E, always think of only acute. Hepatitis E, yes, it can cause chronic infection if the patient is extremely immunocompromised, like a pre-existing HIV or patients on cancer chemotherapy. Otherwise, recovery or death is a rule, right? Mostly in pregnant women, it causes fulminant hepatic failure and death is possible. Otherwise, most of us recover. So the statement D is false. 10% of cases may be converted to chronic hepatitis in 5 years is false. And that would be the answer. Okay. Yeah, hepatitis B antibodies. Okay, so let me put a small scenario. Now, hepatitis B, there are few antibodies. First thing is whether patient right now has an infection or not, right? How do I recognize that? That is with the help of hepatitis B surface antigen. If I have the surface antigen positive, that means there is an infection which is present. If the surface antigen is negative, there is no currently ongoing infection. It does not mean that patient did not have a past infection. Patient might have had a past infection, but he has recovered from it. In that case, HbS-AG will be negative. Any question where HbS-AG is positive, that means there is an infection which is present. Okay. Now, once we have the infection confirmed that, okay, patient has an infection, my question is to know whether it is acute or chronic. For that, my next step would be to look for the anti-hepatitis B core antigen, anti-HBC antibody. Because see, remember the core antigen is not released in circulation, we can only recognize its antibodies, right? And what am I interested? Mainly I am interested in IgM. Okay, IgM, if it is positive, right? If it is positive, that means I am dealing with a case of acute infection. And if it is negative, that means there is no acute infection. Now, if I have a HbS-AG positive and anti-HBC IgM negative, that means I have infection, but it is not acute, right? It is long standing or it is persisting for more than few weeks. It is mostly chronic, right? So it indicates that mostly I am dealing with a case of chronic hepatitis B infection. Here, please remember, chronicity is technically defined as HbS-AG positive status for more than 6 months. If it is for more than 6 months, then I would call it as a chronic hepatitis. That's why I did not directly call it as chronic here, because see, this anti-HBC IgM may stay positive for 6 weeks to 3 months and after that it disappears. Right now, if I'm seeing a patient between the onset of symptoms with 3 to 6 months after the onset of symptoms, this would be negative. right? But I cannot still call the case as chronic because I need to have 6 months of the duration of symptoms. But for practical purpose, you would say that if I have HBsAg positive and anti-HBc IgM negative, it is certainly not acute infection. It could be mostly chronic infection. So now if I give you a antibody profile, you should be able to differentiate whether infection present or not, and if it is present, it is acute or chronic. After that, we have to look at the replicative status, whether the virus is highly replicating so that the patient may be highly infective or no, right? So for that, we look at the HBe antigen, right? If HBe antigen is positive, that means it indicates high replication, and which also indicates that there is high infectivity. On the other hand, if it is negative, it can mean two things, right? It can mean either, first thing is that there is low replication, and that means there is low infectivity, or the other possibility is that the patient has got a mutation. We call it as, not the patient, the virus, we call it as pre-core mutant. So either it could be pre-core mutant variant, and in those cases there is no production of the E antigen, that's why it will be low, or there is genuinely low replication, and that is why we have HBeAg which is negative. Okay, now one more antibody that we would hear is anti-HBs antibody. Now we have to remember one point here, Abhinav. Anti-HBs antibody basically is a neutralizing antibody, and when I say that, you have to remember its target antigen is which one? The target antigen for anti-HBs, as we know, is going to be HBsAg, and they are mutually exclusive. Now what do I mean by that? When I say mutually exclusive, that means once your body starts producing anti-HBs antibody, HBsAg has to go. There is no choice for it. So you don't get to see patients where both are positive. Either you will have anti-HBs antibody positive or the antigen positive. So this appearance of antibody indicates that you have developed the immunity against hepatitis B, and hepatitis B is no longer going to be an infection active in your case. Simple. Okay. So it indicates seroconversion and recovery. Okay. Now I will give you a few examples. You tell me how would you label those patients, right? So first example, I have a patient who is having HBsAg negative, anti-HBs positive, and anti-HBc antibody which is negative. Second patient, HBsAg negative, anti-HBs positive, and anti-HBc IgM negative, and anti-HBc IgG which is positive. And I have a third patient who is having HBsAg positive, anti-HBc IgM negative, okay, and is having HBeAg positive. Let us interpret one by one, right? So in the first case, HBsAg is negative. That means there is no current infection, right? As simple as that. There is no current infection. But he has antibodies, right? And there is no evidence of past infection also, because if we had past infection, then anti-HBc IgG would have been positive, because that stays long time. So neither there is evidence of past infection nor there is evidence of current infection, but he has antibodies against the surface antigen. So this is typically possible when patient has been vaccinated. Ashutosh, right, absolutely right. So this is a case of vaccination. Do you know what do we use in the vaccine? The antigen that is used in the vaccine is nothing but purified surface antigen. So we inject HBsAg, and obviously body will produce antibodies against that surface antigen itself. Simple. Okay. Now the second scenario. Anybody is commenting about the second scenario? HBsAg negative, anti-HBs. See, when I say HBsAg negative, that means there is no current infection. The best evidence of current infection is HBsAg positivity. So currently infection to nahi hai, right? But he has anti-HBs positive. Okay. And when I look at his HBC, IgG is positive, right? This HBC IgM positive means acute or recent infection. IgG positive means past infection. So I have evidence of past infection which has led to production of these antibodies, and these antibodies have converted the patient from the infection to non-infection state, right? So this basically indicates the past infection, and this patient is immune now because he has got the antibodies. So his chances of getting a HBV infection is very minimal because he has antibodies against it. Obviously that depends on the antibody titer. Higher the titer, lesser the chances of acquiring infection. Okay. Now what about the third scenario? Third scenario, HBsAg is positive. That means this patient has a current infection, right? Current infection is present when you say HBsAg is positive. Now all I need to know is whether it is acute or chronic. If anti-HBC IgM is positive, then I would call it as acute, right? That is negative. So this has to be a case of chronic HBV infection. And here the HBeAg is positive. That means the virus is highly replicative, and that also means that the patient is highly infective. So this is chronic hepatitis B virus infection where the patient is highly infective. So this will be our approach to interpret the hepatitis B profile. I know you get graphs and all in microbiology, but it is a bit difficult to picturize. So I would suggest to follow this approach, right? Look for HBsAg to decide whether infection is there or not. Okay. If infection is there, whether acute or chronic, for that decision, base it on the anti-HBC IgM antibody. Positive hai to acute, negative hai to acute nahi. To decide about the infectivity and the replication status, look at the HBeAg. Positive, that means high replication, high infectivity. Negative means low replication, low infectivity. And if the HBs antigen is negative, but still you have the surface antigen ke khilaf antibodies are positive, then only two possibilities. Either patient has been vaccinated or patient had the infection in the past. So if it is a vaccinated case, the only thing that will be positive is the antibody. But if you have the anti-HBC antibodies positive along with the antibodies, that means you have a past infection. Simple. Okay. Next, which of the following statement is true regarding serum HBeAg antigen? I think we were talking about it, so probably this will be solved here itself. So first statement is persistent of HBe beyond 3 months indicates clinical remission. That is obviously false, right? If HBeAg is persistently positive beyond 3 months, it means actually there is active viral replication happening though. So that is obviously false. Okay. It appears in serum during incubation period shortly after the detection of HBsAg. Yes, this is true. If you open up your microbiology textbook, the first antigen that is rising is obviously going to be HBsAg. Soon after that, there will be a next small peak graph that is representing HBeAg, right? The only antigen that doesn't come into circulation and we don't detect is the core antigen or HBC. We can only detect the antibodies against it. So this is also a true statement. Okay, next. Both of the above cannot be the answer. Then persistent of HBe beyond 3 months indicates clinical cure. So option A and D make the same sense and they're obviously false. So I will go ahead with option B as the true statement. So in terms of sequence, first antigen to be detected is HBsAg followed by HBeAg. We don't detect the core antigen in the patient's plasma. We can only detect the antibodies against the core antigen. First to come is IgM and first to go is IgM. That is why we use IgM as a marker of acute infection. Okay. Now we are moving next. A 30-year-old female patient has presented with complaints of pain in the right upper abdomen. Pain in right upper abdomen since 6 days and associated with nausea, malaise and joint pain. She underwent cholecystectomy 5 years back. Investigation shows bilirubin which is high, SGOT, SGPT, normal range for SGOT and SGPT is less than 40 international units per liter. So here it is clearly elevated. Okay. And alkaline phosphatase, which is also elevated. Generally it is less than 120. So I have elevation in alk-phos. Alk-phos elevation is relatively minimal, but I have gross elevation in the liver enzymes, and I have bilirubin, which is grossly elevated, right? Now, do you think this can be one of the congenital hyperbilirubinemias? No, right? Because in congenital hyperbilirubinemias, basically what happens is you will have only elevation in bilirubin. Whether it is direct, indirect, that will help us to differentiate the different subtypes of inherited hyperbilirubinemias. But in all other conditions, you will have associated LFT abnormalities, right? Like in this case, hyperbilirubinemia is there, but along with that, other LFT abnormalities are there, and that itself rules out congenital hyperbilirubinemia. It has to be one of the organic diseases. Okay. Now, in this case, there are few things which I can comfortably rule out. The first thing that I can comfortably rule out is the acute cholelithiasis, because patient has undergone cholecystectomy. Otherwise, that would remain my first and the most important differential diagnosis. Why? Because I am dealing with a relatively young female. Generally, in your surgery, they teach that fatty, fertile females are risk factors for cholelithiasis, right? Fs. So here for female at 38, she is still fertile, and she may be obese as well, right? So female gender is as such a risk factor for cholelithiasis, but here she has undergone cholecystectomy, so that I will rule out. Okay. Now, can I make the diagnosis of acute pancreatitis from the question, information given in the question? No. To make the diagnosis, I need the evidence of elevated amylase or lipase. So here, there is nothing mentioned about the amylase or lipase. If examiner wants me to make the diagnosis of pancreatitis, he should mention either elevated amylase or lipase. Okay, can anybody tell me which one is more specific for the pancreatitis? Is it lipase or amylase? Remember guys, it is the lipase which is more specific for pancreatitis. It is the lipase which is more specific for pancreatitis. Okay. Now what am I left with? Acute hemolytic crisis and acute viral hepatitis. Okay. Now again, to say that this is hemolytic crisis. In hemolytic crisis, yes, jaundice is known to happen, but there are few points. Generally, in cases of hemolysis, the bilirubin levels are usually less than 4 milligrams per deciliter. It won't go so high. Like 8, 9, 10 is unlikely. Unlikely in patients with the hemolysis. First point. Second, to make a diagnosis of hemolytic conditions, I should also have anemia, right? Now there is no anemia being mentioned here. So examiner is not giving me sufficient information to call it as a case of hemolytic crisis. Can it be viral hepatitis? Well, viral hepatitis, especially in the acute conditions, typically presents with the same symptoms that we are describing here, right? Nausea, malaise, joint pain, upper abdominal pain. The presentation is definitely an acute presentation. And in acute viral hepatitis, we can see SGOT, SGPT even go in terms of thousands, right? I have seen patients with 5,000, 6,000 SGOT, SGPT without any major issue. So this is a typical clinical picture of acute viral hepatitis. So I will go ahead with option D as the answer. Okay. Now next. Right, Ashutosh, it is the lipase which is more sensitive for the pancreatitis. Okay. In which of the following condition ALT is more than AST on liver function tests? Except, okay, so basically the question is all of the following conditions will have ALT more than AST except. Okay. So now please remember we do these two tests, right? ALT and AST. Can anybody tell me which one is more specific for the hepatocyte injury? Is it ALT or AST? Which one is more specific? See, if I have a patient with hepatitis B, chronic condition, and I need to start him on the medications, will I base my decision to the AST? Like if AST is high, I will start medication, or the guidelines talk about ALT. If ALT is high, we should start medication. Anybody is giving me an answer? Ashutosh, viral hepatitis is not purely a hepatocellular pathology. There will be minimal intrahepatic cholestasis happening, but we will not have ALP rise significantly. This much rise is very common in patients with acute viral hepatitis. Okay, so now between ALT and AST, which one is more specific to liver? Right, it is the ALT. Right, ALT is hepatocyte specific. Hepatocyte specific. AST can be expressed, not can be, it is expressed. It is also expressed in RBCs, right, myocardial cells and skeletal muscles. So if I have a patient who has got MI, I can have raised AST. If I have a patient who has got hemolysis, I can have raised AST. If I have a patient with rhabdomyolysis, I can have raised AST, right? So if ALT is elevated, it indicates more of the hepatocellular damage. Okay, now what is the question? In all of the following condition, ALT is more than AST on liver function test except, right? So in what condition AST can be elevated predominantly? You have to remember mainly two conditions. AST elevation more than ALT elevation. The first condition you need to remember is cirrhosis of liver. Cirrhosis of liver. So basically in cirrhosis, the hepatocytes are already replaced by fibrotic cells, and that is why you may not be able to produce good amount of the ALT. That is why your ALT will be relatively lower in comparison to AST. And the second condition is alcoholic hepatitis. Alcoholic hepatitis. I'll tell you why alcoholic hepatitis is a classical example where AST is grossly elevated in comparison to ALT. Okay. Now alcohol is a mitochondrial toxin. It's a mitochondrial toxin. And ALT is a cytoplasmic enzyme. It is present in the hepatocell cytoplasm. And AST is present in the mitochondria. So obviously alcohol will affect the mitochondria more, so AST will be released from the mitochondria. That is reason number one. Now alcohol will not only disturb the metabolism of hepatocytes, but it will also disturb the metabolism of RBCs and skeletal muscle. So you will have release of AST even from those sites. So when you take alcohol and then start causing the liver injury, you're also releasing the AST from RBCs and skeletal muscles, and in the long run even from myocardium, right? Do you remember alcohol is the most common toxin responsible for dilated cardiomyopathy? So in that case, all of these things put together, can I say that in case of alcoholic hepatitis, some amount of ALT is coming from liver and maybe equal amount of or slightly higher amount of AST is coming from liver, but AST is also coming from other sources. So in your blood, AST will be much more than ALT, right? These are the two conditions. And in fact, to recognize that, we have something called as AST by ALT ratio. AST by ALT ratio, which is also called as de-Ritis ratio. De-Ritis ratio. Okay. Now this de-Ritis ratio, if it is more than 2, it indicates possibility of cirrhosis, and if it is more than 3, then it is highly suggestive of alcoholic hepatitis. This is again an important MCQ. Where do you get de-Ritis ratio of more than 3? We get that in patients with alcoholic hepatitis. Okay, so now the answer is very clear. AST will be much more in comparison to ALT in patients with the cirrhosis and alcoholic hepatitis. See, all other conditions, hemochromatosis, Wilson disease and autoimmune hepatitis, the liver involvement is leading to increased ALT and proportionate amount of AST and not higher amount of AST. Okay, so that's about this question. Let's move to the next question. Splenomegaly is seen in all hemolytic anemias except, see, normally hemolysis can be divided into the intravascular and extravascular hemolysis, right? Extravascular hemolysis are the conditions where there will be splenomegaly, generally speaking, because spleen is the site of destruction of RBCs. But the sickle cell anemia is a condition where initially you may have splenomegaly, but sickle cell anemia The spleen also get damaged, and we call something as the autosplenectomy. So in case of sickle cell anemia, long-standing anemia goes into what is called as autosplenectomy, because there are multiple micro infarctions happening in the spleen, and they heal with scarring to the size of the spleen keeps shrinking, and it becomes so small that it is not detectable by palpation anymore. So we call that as autosplenectomy. And because autosplenectomy happens in spleen, I would go with that as the right answer, right? Where I may not have a clearly detectable large sized spleen. Okay. Next. Which of the following is a extrahepatic manifestation? Okay, which of the following is, all of the following are extrahepatic manifestations of hepatitis C except, or which of the following is not an extrahepatic manifestation of hepatitis C? Okay, now the moment I say hepatitis C, alright, in terms of extrahepatic manifestation, always remember the most common extrahepatic manifestation of all viral infections is going to be arthritis. Whether it is hepatitis B, whether it is hepatitis C, whether it is acute hepatitis A, or whether it is acute hepatitis E. In all cases, arthritis will be the most common extrahepatic manifestation. So even in case of hepatitis C, that would be most common, right? Apart from that, the hepatitis C triggers your immune system and leads to various autoimmune manifestations. So all you need to remember is hepatitis C means we are talking about the immune system mediated extrahepatic manifestations, right? And there you have to remember a form of vasculitis called as mixed cryoglobulinic vasculitis. And in patients with the hepatitis B virus infection, there also most common will be arthritis, but other than that, they are prone to develop polyarthritis nodosa, right? So with respect to blood vessels, vasculitis, polyarthritis nodosa is associated with hepatitis B, and cryoglobulinic vasculitis is associated with hepatitis C. Okay. Other than that, you can also have the membranoproliferative glomerulonephritis, psoriasis can happen, autoimmune thyroiditis is very common, you can have autoimmune cerebritis, but typically the intestines are not known to be affected in patients with hepatitis C. So ulcerative colitis is not something that is directly related. And if it was related indeed, then we would have discussed that in the ulcerative colitis discussions, right? Me or the surgery faculty would have discussed. When we talk about ulcerative colitis, mostly we talk about smoking, right? Appendicectomy, because there are established associations, but there's nothing linking the ulcerative colitis and hepatitis C. Otherwise, when we talk about vasculitis, when we talk about polyarthritis nodosa, we definitely talk about hepatitis B, right? Similarly, when we talk about cryoglobulinic vasculitis, we definitely talk about hepatitis C, right? So option D would be the answer here. Okay. Next. Well, this is a bit of a tricky question. So let us see if you can answer. So here we have a 40-year-old woman who is found to be hepatitis B, right? Her serology is as follows. HBsAg is positive. That means, as we know, she has infection which is present. She is infected. Clear, right? Now her HBeAg is also positive. Now what does that mean? She is not only infected, she is highly having active infection, and thus she is highly infective to someone else. Okay. As of now, her liver function tests, coagulation cascade and all are normal. So this infection has not caused any major damage to liver as of now. Okay. Now let us look at her partner. Her partner has following serology. His HBs antibody is positive and HBc antibody is negative. Now what is profile indicating us? Tell me. What his profile is indicating? His HBsAg is HBs antibody is positive, HBc antibody is negative. Now if I give you this much information, I have already told you that HBsAg and antigen against it, anti-HBs antibody, they are mutually exclusive. If one comes, other has to go, right? So when I say HBs antibody is positive, it goes without saying that the surface antigen will be negative. So in that case, he doesn't have a current infection. There is possibility of past infection or vaccination, and looking at this profile, it looks like he was infected, right? So this partner has past infection. He doesn't have current infection, partner has past infection, and the index patient has highly active current infection. Now the question is, which of the following statement is correct? Okay. She has to do her viral load before performing exposure prone procedures. I'll come back to this, what is the meaning of this sentence, but we will look at the other options. Pregnancy and lactation are contraindicated. Do you think we make pregnancy and lactation absolute contraindication when it comes to hepatitis B infection? No, right? We can assess the risk of transmission to the fetus. There are various corrective steps, right? Like taking up the patient for C-section and then giving the medications to prevent the mother to child transmission. So it is not an absolute contraindication, right? So this is clearly a false statement. Okay. Now what about the option C? How many of you think that is true? Her risk of developing hepatocellular carcinoma is high. Her risk of developing hepatocellular carcinoma is high. How many of you think it is true? What we know is chronic hepatitis B infection as such increases the risk of hepatocellular carcinoma, but the risk correlates more with the degree of liver damage. So if I have raised ALT, AST, right, long-standing elevation in AST, ALT, the risk of developing hepatocellular carcinoma is even higher. And if there is an established cirrhosis, the risk is even more higher, right? So in that case, this I would consider it as a partially true statement. I'll come back to it again. Okay. Now last statement. She is at high risk of infecting her partner sexually with hepatitis B. No, the partner is currently immune. So the chances of infection to the partner is less because he has the antibodies against the surface antigen. Well, it obviously going to depend on the titer. If the titer is low, he can still be infected. But making a general statement saying that there is a very high risk of partner acquiring infection from her is unlikely, right? He has probably acquired infection from her, or he may be the reason she got infected, but he is now recovered and immune. So this is clearly a false statement. Now I have to make a choice between option A and option C. Okay, I'm going ahead with option A. I'll tell you why this becomes my correct answer. See, now she is highly infective, right? What if she is a healthcare worker, like a doctor or a paramedic or a staff nurse? Any minor trauma to her and that needle pricking a patient, right, literally means that patient will get infected. We all know that needle pricks or the sharp pricks, the infectivity or a transmission risk is higher for hepatitis B in comparison to HIV, right? So if she is a healthcare worker, then she should make sure that she won't increase the risk of someone else acquiring the infection, and that is why the current recommendation is that if a healthcare worker is doing a procedure where the chance because of the risk of injury to the surgeon or the healthcare worker is high, then they should check their viral load levels and it should be less than 20K to perform the procedure. If it is high, they should not be performing that procedure, right? So I will go ahead with option A, and I would probably believe that the examiner here is giving us hint that her liver function tests are normal. So right now there is no evidence of liver damage. So if there is no evidence of liver damage, the risk of developing the liver cancer is relatively less. So I will count it right now false more than true, and we will go ahead with option A as the answer. Okay, now this is how like questions in your NEET PG get a bit complicated or tricky. So try to think more logically. It is not only going to be based on facts, because facts is facts. Enormous number of facts. You can't remember everything, but some logical thought might take you to the answer. Okay, next question. A 41-year-old man. See, please remember the age of the individual. He is 41-year-old. He is a type 1 diabetes mellitus since 10 years. Okay, and he presented to the outpatient with history of irregular bowel habits since last 5 months. There is no blood or mucus in the stool and had no any abdominal pain. His A1C is 7.5. Liver function test, thyroid, kidney function test, abdominal ultrasound, and even colonoscopy with biopsy are normal. So when you talk about colonoscopy and biopsy normal, it rules out some of the conditions, right? What conditions are ruled out? First of all, we're talking about type 1 diabetes mellitus, and he is present with chronic irregular bowel habits. Now, what are the differential diagnoses in such case? I would think about the irritable bowel syndrome, right? inflammatory bowel disease, celiac disease, Whipple's disease. Then there is something called as diabetic diarrhea. What does that mean? Diabetic diarrhea is because of the autonomic nervous system dysfunction. Okay. And then the last one I would be thinking of is the exocrine pancreatic insufficiency. Exocrine pancreatic insufficiency. Okay, so these are my differential diagnosis. Now, why exocrine pancreatic insufficiency is a differential diagnosis here? Now, if you're not producing sufficient quantity of exocrine output from the pancreas, that is your proteases and lipases, then your fat and lipid absorption will be impaired, right? Digestion will be impaired, and as an outcome, you're not absorbing fat, so you will develop steatorrhea. You're not absorbing proteins, and that will lead to flatulence and diarrhea. So you will have altered bowel habits. So these are all symptoms. Okay. Now IBS is a diagnosis of exclusion, so I have to rule out everything else before I come to IBS. Okay. IBD, well, the colonoscopy is a very good initial investigation, and a biopsy would have definitely identified the abnormal changes. And because biopsy here is being reported as normal, that rule out IBD. Okay. Similarly, celiac disease biopsy would have identified. What pathologies biopsy would have identified in celiac disease? First one, villous atrophy, right? Then crypt hyperplasia, and the last one you will have intraepithelial lymphocytosis. So there will be infiltration of the intestinal epithelium by lymphocytes. And when we look at the histopathology of the liver, the intestines, we have this finger-like projection called as villi, and then deep trenches called as crypts. So what happens in celiac disease is the villi become shorter, crypts become deeper. So I will have villous atrophy, crypt hyperplasia, right? Now, if that was there, then the examiner would have mentioned that in the biopsy that is not there. So probably it is not a case of celiac disease, right? Now, if it is Whipple disease, the examiner would have mentioned that there are pass positive macrophages. That is not there here. Biopsy has turned out to be normal, so that is ruled out. Okay. Now, diabetic diarrhea and IBS are diagnosis of exclusion. I have to rule out everything else before I call it as a case of autonomic nervous system dysfunction. Now, I have to rule out the exocrine pancreatic insufficiency, whether pancreas is producing sufficient quantities of lipases and proteases, right? So now among these tests, which one can really help me to rule out the exocrine pancreatic insufficiency? There are two tests, right? We can test for fat malabsorption and we can test for protein malabsorption. How would I test for fat malabsorption? Mainly we do fecal fat estimation, right? So for fat malabsorption, we do fecal fat estimation. Fat malabsorption. What we do is we give 100 gram of fat in diet for 3 days, and then we will check the fecal fat. And if the fecal fat is more than 7 grams per 200 gram of stool, that is abnormal, right? This indicates that you have got fat malabsorption. We have got fat malabsorption. Okay. And for protein malabsorption, we can check the fecal elastase levels. We can check the fecal elastase level. Okay. Now, similarly, there is a biomarker which can be used for the IBD patients in the stool. Can anybody tell me which one is that? Like how we can check the fecal elastase levels for protein malabsorption? We can check a marker which indicates the bowel inflammation, and that marker is nowadays used for assessing the disease activity in patients with IBD. Which one am I talking about? Anybody is commenting on that? That is what you call as fecal calprotectin, right? Fecal calprotectin indicates that there is inflammation of your large intestine. Fecal calprotectin. What is that? Fecal calprotectin. It's a marker used for assessing the disease activity in patients with IPD. Okay, so now coming back to this question, I have to rule out the 𝐒𝐄𝐝 pancreatic deficiency, and for that my test would be stool for fecal elastase. So option D would be the right answer over here. So here we have long-standing ulcerative colitis. Now ulcerative colitis patients long-standing also, so he will be on immunomodulators, right? On routine test showed sterile pyuria. When they say sterile, that means infection as a cause for the WBCs in the urine is ruled out. Okay. And then there are dysmorphic red blood cells. The moment you say dysmorphic red blood cell, that indicates there is injury to the glomeruli, right? So there is glomerular injury. So I have glomerulitis for sure if you say there are dysmorphic RBCs. Okay. Now there is an additional point here. Patient has got eosinophilia in the urine. That is, I can call it as eosinophil urea. So patient is passing eosinophils in the urine. Eosinophils in the urine generally indicate, this is an important clue in your question. The moment question talks about eosinophils in the urine, it is talking about interstitial nephritis. It is talking about interstitial nephritis, and the most common cause for interstitial nephritis is indeed drugs, right? The most common cause for interstitial nephritis is usually the drugs. Okay, if at all they ask you among the drugs what is the most common cause for interstitial nephritis, right? The most common class of drugs responsible for interstitial nephritis is your beta-lactam antibiotics. Right? So we learned plenty of MCQ points here. Any question which talks about eosinophils in urine is talking about interstitial nephritis. Now what is interstitial nephritis? See, we know there is a nephron. Nephron has a glomerulus. If there is injury to it, we call it as glomerulonephritis. Okay. Then we have this proximal convoluted tubule, loop of Henle, distal convoluted tubule, and the collecting ducts. So this all collectively we can call it as tubules. Now if they are damaged, we call it as tubular injury, like you say acute tubular necrosis and chronic tubular diseases. But these nephrons are all held together by the connective tissue surrounding these nephrons, right? That connective tissue is the interstitium. So when you say interstitial nephritis, there is inflammation of the connective tissue which is holding the nephrons together. Because it is most commonly caused by hypersensitivity to certain drugs, we will see extensive infiltration of eosinophils into the interstitium, and those eosinophils start appearing in your urine, right? As simple as that. Okay. So now he did not had any urinary symptoms and his creatinine is mildly elevated. So basically he has got an acute kidney injury which is probably interstitial nephritis, and drugs are the most common cause for interstitial nephritis. And this patient is a long-standing case of ulcerative colitis. So maybe one of the drugs used for ulcerative colitis is responsible for this interstitial nephritis. Okay. Now, if indeed it was a bladder carcinoma, he would have had frank hematuria, not dysmorphic RBCs. RBCs, when you say dysmorphic, means their shape has changed. The shape will only change when they have to pass through injured glomeruli. Dysmorphic RBCs indicates glomerular injury. As simple as that, right? Now, tuberculosis of the genitourinary system would have caused other symptoms because generally it forms tuberculomas. And again, tubercular genitourinary system infection cannot be explained with the eosinophils that we are seeing here. Okay. Then polycystic kidney disease usually presents as hypertension. The most common presentation of polycystic kidney disease is hypertension. Along with that, they can develop hematuria, but not with dysmorphic RBCs, because polycystic kidney disease is not a disease of the glomeruli, it is a disease of the renal tubules. Tubules are degenerating into cysts, not the glomeruli. So you will not get dysmorphic RBCs. You will get microscopic or frank hematuria, but no dysmorphic RBCs. So that is also ruled out, right? So it is not a case of bladder carcinoma, it is not a case of TB, it is not a case of polycystic kidney disease. The whole picture fits into the typical description of interstitial nephritis. So I will go ahead with option C as the answer here. Okay. Now we will move to the next one. So here we have a 35-year-old man who has underwent a stem cell transplantation 18 months ago for acute leukemia. Now he presents with increasing confusion, jaundice and pain abdomen, right? Now any patient who is presenting with confusion and jaundice, the first thing that should strike my mind is that he is developing hepatic encephalopathy. Okay. Now laboratory results show ALT and AST which are grossly elevated. Normal upper limit is 40, so you can say that the elevation is in terms of 50 or 100 times the upper limit of normal, and GGT is also grossly elevated. But when this patient's USG abdomen and Doppler studies are done, portal and hepatic veins are normal, right? So when portal vein and hepatic vein is normal, I can say that there is no portal hypertension, and it is also not because of the right heart dysfunction. Now they're asking what is the most likely cause for liver failure here. So once they mention that there is normal portal veins, portal vein thrombosis is ruled out. Otherwise, I would have had elevated portal vein pressure if I had the portal vein thrombosis, right? That is ruled out. Okay. Then hepatic vein thrombosis, what we call as Budd-Chiari syndrome, that is also ruled out because they only have told that hepatic vein is normal. So I'm left with only two options: graft versus host disease, option B, and herpes simplex hepatitis. Okay. Now graft versus host disease, we are not dealing with the liver transplantation here. Patient has undergone the bone marrow transplantation, stem cell transplantation, because he had a leukemia, right? So even if he develops the graft versus host disease, the predominantly affected organ will be the marrow. Liver can be affected, but not to the extent of going to hepatic encephalopathy, right? That is first point. Then second point, if it is a graft versus host disease, it has to be a chronic graft versus host disease and not acute rejection. In acute rejection, yes, I might have a fulminant hepatic failure, but this is not the picture of acute rejection. So keeping these 2 points in mind, I am moving away from this and leaning towards herpes simplex hepatitis. Now it becomes a very important diagnosis here, because patient, once he underwent the stem cell transplantation, he would be on immunosuppressants, and those immunosuppressants increase the risk of secondary infections, and one of them is herpes simplex. Most dreaded or feared one would be cytomegalovirus, but herpes simplex is also relevant, especially as a chronic hepatitis. Means 6 months after the organ transplantations, the risk of herpes simplex significantly increases. And keeping that point in mind, we are going ahead with option D as the answer here. Okay, next question. So here I have a 45-year-old female who is admitted in comatose state and diagnosed as acute liver failure. Acute liver failure, right? So basic understanding of acute liver failure is acute liver failure is equal to impaired liver function to the point leading to either hepatic encephalopathy and or coagulopathy. So any patient with impaired liver function, if the impaired liver function have led to hepatic encephalopathy or coagulopathy, it will be counted as a case of acute liver failure. Most important here is to consider encephalopathy. If any patient of liver dysfunction has developed acute encephalopathy, it is in acute liver failure. Even if it is a case of CLD, we would call it as acute on chronic liver failure. Okay. Now, which of the following statements, his viral serology, serum ferritin, copper and autoantibodies, alpha-1 antitrypsin are all normal as reported in this question. Which of the following statements regarding hepatic drug toxicity is true, right? Nowadays, in the Western world, the most common cause for acute liver failure is drugs, right? There are a few MCQ points. Let me list it down. The first point is the most common cause for acute liver failure in the world, or if you specifically ask the Western world, in both those cases, your answer would be drugs. Drugs are the leading cause. And among the drugs, the most common drug that is responsible for hepatotoxicity is nothing but paracetamol. Right? I don't know, for some weird reasons, paracetamol in India doesn't do much harm to the liver. Well, it is. I know I have seen patients where they have developed fulminant liver failure after paracetamol toxicity, but I've also seen plenty of patients who have taken even lethal doses of paracetamol and they walk home comfortably from our ICUs. Okay, so now to remember that the most common cause for acute liver failure in India is hepatitis, viral hepatitis is viral hepatitis and not drugs. And when it comes to viral hepatitis, among the viral hepatitis, the most common cause is hepatitis E. And this whatever answer I'm giving may not be agreed by some of the microbiology teachers, but this is from the government of India official data. They have released the data saying that in the previous years, majority of the liver transplantations that happened following acute liver failure were because of the hepatitis E acute infections. Okay, so those are the two MCQ points. Okay, now let us look at the options. Now MRI scan will be, abdomen will be helpful? No, right? When drugs cause liver dysfunction, there will be no major change on the MRI of the liver. So this is false. Okay. Now option B, I'll come back to it. Fibroscan of the liver is useful for the prognosis? Absolutely no, right? What is useful for the prognosis? There is something called as King's College criteria, right? King's College criteria, which can help us to predict the prognosis in the drug-induced liver injury. Okay, and there is one more criteria called as ALFED criteria. ALFED criteria. These two criteria can help whether this patient will make it or he will succumb to it. Now, liver transplantation is contraindicated is absolutely false, because at least half of the patients will require liver transplantation if it has caused the fulminant liver failure. And many of them die because of the difficulty in arranging the liver transplantation from happening. So that is false. Option C is false. So we're left with option B. A history of herbal remedies may be relevant. This is not just relevant. The single most important thing that if I have a patient who has an abnormal LFT which is not explained by any of the known disorders, like I have taken into the consideration the approach to jaundice and the assessment of liver function, and these are not leading to the diagnosis, the first thing that I should do is spend some time with the patient and attenders and see if he is taking herbal remedies. There are a lot of herbal brands which promote weight loss remedies or skin fairness remedies, and they are loaded with toxins which can impair hepatic metabolism and cause acute liver failure. So please don't miss out. Every time you have a patient with unexplained LFT abnormality, ask the history of the traditional medicine and herbal remedies. Okay. Next, a 49-year-old woman is admitted with generalized tiredness and weakness, no history of fever or pain abdomen or diarrhea. On examination, she was poorly built and icterus was present. There are no other abnormal physical signs. What is the most likely diagnosis? So basically, if I have to give you one word summary of this patient's question, that would be painless jaundice, right? She doesn't have abdominal pain, but she has jaundice, painless jaundice. Now, in case of the viral hepatitis, some degree of abdominal pain is very common, right? Now, in case of the cholelithiasis causing the obstruction to CBD, abdominal pain or the colic is very common, right? If I have a carcinoma of the gallbladder, pain is very common. But when you have a pancreatic head cancer, see, the most common site of cancer is the head of the pancreas. That is the most common site of cancer. Majority of the cancer happen here. Okay. And now that is the location where your pancreatic duct joins your common bile duct to lead into your duodenum. Okay. So this expanding head mass can easily cause the obstructive jaundice. So it presents as obstructive jaundice, but because it is not very pain sensitive and not invading the pain sensitive structures initially, you will have painless obstructive jaundice. As it invades the surrounding structures, pain will appear, but to start with, it is painless jaundice. So anytime question talks about painless jaundice, think of the carcinoma of the pancreas. think of the carcinoma of the pancreas. Okay. Chronic pancreatitis will be characterized by recurrent abdominal pain. Whenever there is pain, there will also be elevation in the lipase. Okay. Gallbladder cancer will, in addition to the abdominal pain, would be there here. That too, the nature of the pain would be colicky. And primary biliary cirrhosis, I cannot make a diagnosis without the presence of antibodies. Right? Okay. Next question. A 45-year-old male patient who is HIV positive, who is not compliant with his treatment, now presented with diarrhea. Okay, now the differential diagnosis for an HIV presenting with diarrhea is quite long, right? You can have cryptosporidosis, right? You can have amoebiasis, you can have cytomegalovirus colitis, and you are also prone to develop the inflammatory bowel disease, small intestinal bacterial overgrowth. These are all differential diagnoses for a patient with HIV presenting with diarrhea. Okay. Now, sigmoidoscopy showed mucosal inflammation, focal hemorrhages, polypoid lesions, and edematous foot. So as of now, I would say that there is evidence of colitis, right? So basically, we are dealing with an HIV positive individual who has developed colitis, and cryptosporidosis, Mycobacterium avium intracellular infection. These are all differential diagnoses in that case. But there is one point here. On biopsy, we could see inclusion bodies. Typically, the cryptosporidosis or the Crohn's disease, we will not get inclusion bodies, right? So if you have a colitis with inclusion bodies in an HIV, we should start thinking about cytomegalovirus colitis. There typically you will see giant macrophages with inclusion bodies. Okay. So I would go with option B here, mainly because the question talks about the inclusion bodies being present. Cytomegalovirus colitis. Okay. Next. A 38-year-old female recently admitted in hospital with salmonella. So we are talking about the enteric fever, and she has come with loose stools, mild abdominal pain. Which of the following statement is less relevant in managing the patient? Okay, so what are we dealing with? Salmonella gastroenteritis. Now, if I have to deal with the worst case of salmonella gastroenteritis, what can I expect? Right. So salmonellosis in worst case scenario leads to two complications. The first one is septicemia, or salmonella circulating in blood causing other organ dysfunction. Septicemia leading to multi-organ dysfunction syndrome, that leading to death. That is one worst case scenario. The second worst case scenario is because salmonella predominantly affects the terminal ileum, right? There you can have the ulcers, and it also affects the colon. There also you can have ulcers. So it can lead to ulcers, and these ulcers, especially the ileal ulcers, can perforate. Perforation is my second concern, right? Other than this, I am not expecting any other major complications, right? Now let us look at the statement. Request a colonoscopy. See, please remember, when you have a very friable tissue, right? When you have a colon which is highly friable, easy to break down, as in case of acute infections, colonoscopy is relatively contraindicated, because just merely the act of passing the colonoscopy tube trying to enter into the terminal ileum itself may be the reason that the patient will develop perforation. So it is a relative contraindication. Anyway, I'll come back to that. Rehydrate patient orally or intravenously as required. Yes, salmonella patients have fever. They will be dehydrated because they have diarrhea. They will be sweating profusely. So they will require fluid replacement. Depending on the degree of dehydration and patient tolerance, you can give either orally or IV. So, right? So this is certainly a true statement. Okay. Now I will come to option C later. Let us also look at option D. Send stool culture and sensitivity including Clostridium difficile toxin. Okay. See, now when you look at this story, and there is another point. The patient had salmonella gastroenteritis, and now she has come back with loose stools. Now, anytime someone who was treated with antibiotics, if they come back after initiating antibiotics with loose stools, there's also a possibility that they might have developed Clostridium difficile infection, right? That is a possibility. Or another possibility is that whatever antibiotics you gave hasn't helped the patient, and patient continues to have the salmonella enteritis. So whether there's active infection or not, how would I get to know? Maybe with the stool culture. See, in the first week it is blood culture. right? In the second week, it is viral test. In the third week, it is stool culture. And after that, if there is further possibility of the existing salmonellosis or the chronic carrier state, then we need to do the biopsy from the gallbladder, right? Cholecystectomy and the gallbladder culture, right? This is the investigations. So here, I would think of doing the stool culture to see whether there is active salmonella infection present and whether patient has developed C. difficile infection because of the antibiotics. So this makes sense. So I will count this as true. Now, if I have to choose between option A and C, I would go ahead with option C. The reason for that is X-ray abdomen can help to identify the perforation, because if there is an intestinal perforation, there will be gas under the diaphragm, right? So if there is perforation, I will see gas under the diaphragm. Okay, and CRP will generally correlate with the degree of inflammation. It is an inflammatory marker, so it does help me in prognostication. Right? So keeping all that in mind, and because in acute infected status, the colonoscopy is a relative contraindication, I would go ahead with option A, right? Okay. Next, we have a 30-year-old, right, longitudinal ulcers, amoebiasis, horizontal ulcers. Okay, now a 30-year-old woman has come with pain abdomen. Her liver function tests are all normal. Ultrasound report shows multiple hyperechoic lesions in both lobes of the liver. There are no features suggestive of cirrhosis or portal hypertension. Intrahepatic and extrahepatic biliary tree is normal. Spleen, pancreas, kidneys are all normal. What is the most likely diagnosis? Okay. Now it can't be multiple metastasis, because if there is metastasis, whatever areas, right, let me say that this is the liver, and if there are multiple metastasis, those areas of metastasis will not be metabolically active. So patients often develop jaundice, right? And these lesions may be compressing the intrahepatic biliary tree and they may be causing some degree of obstruction. So I would obviously expect an abnormal LFT, which is not there. Okay. Then liver abscess. Liver abscess will not be a hyperechoic lesion, but rather a hypoechoic lesion. Same applies to the cysts, right? So whenever you have fluid filled spaces, they will be hypoechoic. So I can comfortably rule out liver abscess and multiple cysts in the liver the moment they say that it is a hyperechoic lesion. And apart from that, liver abscess would obviously cause LFT abnormality, right? So liver abscess should be associated with abnormal LFT. Multiple metastasis will usually be associated with abnormal LFT. So these things are ruled out. Multiple liver cysts may be asymptomatic. LFT may be normal, but they will be hypoechoic, right? Fluid is not a good conductor. So now what am I left with? Mainly hemangiomas, right? So hemangiomas can appear as multiple hyperechoic lesions in the liver, and patient may largely remain asymptomatic. So that's why option A becomes the right answer. Okay, next. Here we have a 75-year-old man who has come with 10-day history of jaundice with any pain abdomen. He is lethargic but otherwise well. Liver function test shows cholestatic picture. Hepatitis serology is negative. Ultrasound shows no hepatomegaly or duct dilation. He received recent course of an antibiotic for cellulitis. Which of the following medication is most likely responsible, right? So here we are talking about cholestatic jaundice. Cholestatic jaundice. Now when you say cholestatic jaundice, the cholestasis can be either intrahepatic or extrahepatic, right? So if there is extrahepatic obstruction, ultrasound can easily identify. So here the ultrasound is not showing any duct dilatation. That means there is no extrahepatic obstruction. So this is mostly a case of intrahepatic cholestatic jaundice. So this is not because of a CBD being obstructed by a gallstone or a pancreatic cancer causing obstructive jaundice. In that case, we can clearly see the dilation of the common bile duct and we could have recognized it. Now, for the intrahepatic cholestatic picture, you can have that in viral hepatitis. You can have that as drug-induced. And when it comes to drugs as causes for cholestatic jaundice, I want you to remember mainly two classes of drugs. The first one is beta-lactams. And the second one, which used to be an important examiner's hot topic during our times, that is your erythromycin. Erythromycin. Okay. Other than that, yes, oral contraceptives, pills too. Right? These are important drugs which are known to cause intrahepatic cholestasis. Okay. So now when we look at the options, right, atorvastatin, yes, it is also known to cause the cholestatic picture, intrahepatic. Amiodarone also known to cause. Diclofenac, I have not come across case reports, but I'm sure about atorvastatin, amiodarone, but these are not antibiotics. Here they're clearly mentioning and they're asking, like they were mentioning that he was given antibiotics for cellulitis, and after that he has developed this jaundice, so it has to be drug induced, it has to be the antibiotic induced. So that rules out atorvastatin, amiodarone, and even diclofenac. So I'm left with only one option, that is the 𝐒𝐿, right? Amoxicillin clavulanic acid combination, which is a well-known drug to cause intrahepatic cholestasis, and that becomes my answer of choice. Okay. On routine health check, a 18-year-old female is found to have the following test. Gender is female, hemoglobin is 13.7, reticulocyte count is fair, liver function test, bilirubin is 3, AST, ALT are normal. I have told you normal upper limit is generally 40. Alkaline phosphatase is also normal, albumin is also normal. What is the most likely diagnosis? So now I have jaundice, right, without other LFT abnormalities. The moment I see jaundice without other LFT abnormalities, I know what I'm dealing with is a case of congenital hyperbilirubinemia, right? So this indicates congenital hyperbilirubinemia. And there we had learned an approach, right? What is that approach? If we are dealing with the direct predominant hyperbilirubinemia, or whether we are dealing with the indirect predominant hyperbilirubinemia. For direct, I told you to remember D for Dubin-Johnson and direct ka R for rotors. R for rotors. And for the indirect, I gave you a mnemonic, that is computer generated imagery, or CGI, right, where C stands for Krigler-Najar and G stands for Gilbert. Okay. Now in this case, they have only mentioned the bilirubin levels, right? They're not talking about the direct versus indirect. They have not given how much is conjugated, how much is unconjugated. Now how will I differentiate when I don't know that? There are a few pointers which will help us to differentiate, right? What are those pointers? I will give you some points which favor the correct answer here and some points which also go against the correct answer, right? The first thing is, among all these, what is the most common in inherited hyperbilirubinemia? The most common is going to be Gilbert syndrome. So this is again an MCQ point. Most common inherited or congenital hyperbilirubinemia is Gilbert. Okay. Now typically Gilbert is more common in males than females. In this case it is female, so that is one point which is going against our answer here, but otherwise I am not saying that it is exclusive to males. It is more common in males than females. And here the bilirubin levels generally does not exceed 3. So it is usually less than 3 milligrams per deciliter. Okay, clear? Now, the usual age of presentation of Gilbert syndrome patient is in their second to third decade. So mostly when they are in their teenage to the time they become 30 years. That's the usual age range of presentation. So here also age range fits into it. So age wise it fits, gender wise slight deviation. Otherwise rest of the things fit in terms of picture. Okay. Now, the Krigler-Najar syndrome, right, it is usually evident by birth, and so is Rotor syndrome. But Dubin-Johnson is one more condition which can present usually in teenage or adulthood, right? Same as your Gilbert syndrome. So Dubin-Johnson and Gilbert syndrome are the two congenital hyperbilirubinemia which I will be seeing as an adult physician, right, as an internal medicine practitioner. On the other hand, the Rotor syndrome and Krigler-Najar, right, CR, these two are the ones which are seen by the pediatricians, not by the adult physicians. Clear? Okay. So now, what is the point that goes against Dubin-Johnson syndrome? Dubin-Johnson syndrome is very rare. Very, very rare. Gilbert syndrome is very, very common. Dubin-Johnson syndrome is very, very rare. And there is a common dictum saying that if you diagnose a rare disease, you are rarely correct. Right? So keep that in mind. Second thing is bilirubin in Dubin-Johnson is slightly higher in comparison to Gilbert. So the bilirubin ranges from 1.8 to 7 milligrams per deciliter. So keeping these 2 points in mind, that bilirubin here is relatively on the lower side, right? I am going ahead with Gilbert syndrome as my first preferred diagnosis, and my second preferred diagnosis would be Dubin-Johnson. In real scenario, I will look into the predominance, whether it is direct predominant to Dubin-Johnson, indirect predominant, it will be Gilbert, right? But at least here, if I have to make one choice, I will go ahead with option D, Gilbert syndrome, because it's common. The age of presentation fits into it, and the bilirubin level also fits into it. So I'm going ahead with option D as the answer. Okay. Next, we have a 42-year-old male who presented with loose stools, fever, weight loss associated with breathlessness and progressive weakness of his legs. Examination was unremarkable. CRP is grossly elevated. Hemoglobin is in the lower side, and his MCV is normal. Upper GI endoscopy was normal. CT thorax shows pleural and pericardial effusions. CT abdomen shows transverse colon cancer. Okay. Now this is a very, very important point. His blood culture gives Streptococcus bovis. Now please remember, when we talk about infective endocarditis, they will ask you a question. Which of the following is a risk factor for Streptococcus bovis infective endocarditis? And most important risk factor is the colon cancer, right? So patients who have colon cancer, there is an easy entry of the Streptococcus bovis into your circulation, and from the circulation it is easy to reach the endocardium, right? So in patients with colon cancer, there is increased risk of Streptococcus bovis infective endocarditis. And every time you have diagnosed a case of colon cancer, you should check for the Streptococcus bovis infection, and if it is there, you need to evaluate for the presence of infective endocarditis, because you may be able to treat the cancer, you may be able to resect the cancer, but if you don't recognize that he has got infective endocarditis, you may end up losing him for endocarditis, right? Okay, so now given the information, what would be the right answer here? Now we already know that there is a colon cancer on the CT abdomen, right? So there is no point in further evaluation. Then pleural aspiration, well, it is not a priority. ANA profile, okay, what are we doing here? Like ANA profile is relevant when you're thinking of an autoimmune disorder. Here everything is fitting into an infection. The organism, the underlying risk factor, everything is pointing towards the possibility of infective endocarditis, and I need to evaluate for that, and the investigation of choice for that would be echocardiography. Now what am I going to look for in the echocardiography? Mainly the vegetations on the valve leaflets, right? To look for those vegetations on the valve leaflets and also the regurgitant lesions that the patients develop, mainly MR, I would go ahead with the echocardiography, right? So in infective endocarditis, they will ask you what is the most common valvular lesion. The most common valvular lesion is going to be mitral regurgitation. Why that happens? Because as we know, mitral valve, there are two leaflets and they have these caudate tendineae anchored to papillary muscles, and because the vegetations form on the under surface of this caudate tendineae, there can be a rupture of the caudate tendineae, and once there is a rupture of caudate tendineae, the leaflets won't stay in place, they open up in the opposite direction, allowing the regurgitation. That's why MR is the most common valvular lesion. Okay, next, what is the most common cause of death in patients with rheumatoid arthritis? Simple. You talk about any autoimmune disorder, especially the rheumatological disorder, SLE, scleroderma, or your rheumatoid arthritis, Sjogren's syndrome. In most of these patients, there is accelerated atherosclerosis. That means atherosclerosis progresses quite faster. And because of that, the cardiovascular abnormalities and stroke risk is high in them, and majority of them don't die because the joints are getting affected or the pleura is getting affected. Mostly they die because of the coronary artery disease, right? So if they're asking you what is the most common cause of death in rheumatoid arthritis, flat out the answer should be ischemic heart disease, nothing else there. IHD would be the answer. Okay, next. A 30-year-old RA patient is planning for pregnancy. Which of the following drug cannot be used? So we are talking about a patient with rheumatoid arthritis. For rheumatoid arthritis patient, right, for RA patient, the drug of choice, if you ask me, the answer has to be methotrexate, right? Methotrexate is the drug of choice. Now, alternative to methotrexate, what else I can use? I can use drugs like leflunomide, or I can use drugs like sulfasalazine, and I can use drugs like hydroxychloroquine. But the preferred drug will be methotrexate. But methotrexate is clearly contraindicated in pregnancy, right? So please remember, methotrexate is contraindicated in pregnancy. I can't use it, right? So I have to think of the other drugs. Now, among the other drugs, even leflunomide is contraindicated in pregnancy. So what am I left with as first line agents? I am left with sulfasalazine and hydroxychloroquine. Steroids can anyway be used in a patient with pregnancy. So I can use prednisolone, I can use sulfasalazine, I can use hydroxychloroquine, but I cannot use leflunomide, and also I cannot use methotrexate, right? So please be aware of this. Instead of asking this way, they can ask you which of the following drug can be considered in place of methotrexate in a pregnant woman who is having rheumatoid arthritis, right? You have to choose either sulfasalazine or hydroxychloroquine. Okay. Now, before I go forward, let me also tell you that hydroxychloroquine is the first line agent when it comes to SLE, but for rheumatoid arthritis, it is not as effective. So it is considered as an alternative. The best drug is still methotrexate. Okay. Next, the triad of neutropenia, splenomegaly, and nodular rheumatoid arthritis is seen. Now, this is known to all of you. The answer is Felty syndrome, right? Then comes the question, what is Kaplan syndrome? What is Kaplan syndrome? Anybody giving me an answer? What is Kaplan syndrome? Kaplan syndrome is combination of rheumatoid arthritis plus pneumoconiosis. Pneumoconiosis. Usually that could be either Kohl-Werkers pneumoconiosis or silicosis. In both these patients, there is increased exposure to silica, and we should remember that silica is an immunoadjuvant that increases the risk of autoimmune disorders, including rheumatoid arthritis. So if pneumoconiosis leads to development of RA, this combination is what we call as Kaplan syndrome. Okay. The next thing is Evans syndrome. Okay. Now, what is Evans syndrome? Evans syndrome is where you have a combination of autoimmune hemolytic anemia plus ITP, immune thrombocytopenic purpura. So if you have a combination of AIHA plus ITP, that is Evans syndrome. Sjogren's syndrome, all of you know, right? So the answer for this would be option A. Most of the time students confuse between Felty syndrome and Kaplan syndrome because both of them have rheumatoid arthritis. Okay. Now the given CT shows. Probably this CT, if they're talking about the patterns, it is about an ILD, right? So there are two patterns of ILD. First one is called as UIP pattern, which is characterized by formation of honeycomb appearance, and NSIP pattern is characterized by presence of ground glass opacities. What we see here are basically ground glass opacities. Now, what are ground glass opacities? Those opacities which are not fully opaque and not fully translucent, making it the normal lung appearance, somewhere in between. Right? Opacity is there, but through those opacities you can see the bronchiovascular structures. Then we call it as ground glass opacities. In fact, what we see here, these are all ground glass opacities. Okay, see, normal lung would probably look aerated, somewhat darker like this you're seeing here. Right? Otherwise, what you see here and all is not as opaque as this, at the same time not as translucent as this, somewhere in between. So these regions are what we call as ground glass opacities. So the moment I see ground glass opacities, if I am a radiologist, I will report it as NSIP pattern. NSIP pattern is typically seen in patients with the NSIP type of ILDs, which include connective tissue disorder related ILDs and idiopathic NSIP, idiopathic non-specific interstitial pneumonia. UIP pattern is characterized by extensive bronchiectasis giving rise to the appearance as honeycomb, and that is typically seen in patients with idiopathic pulmonary fibrosis. If there was pleural effusion, I could have seen the separation between the two layers of pleura, dark separation, which I don't see here, so it is unlikely to be the pleural effusion. Okay. So correct answer would be option B. Okay, next. In patient diagnosed with inflammatory bowel disease, if diarrheal symptoms are predominant, all of the following drugs can be used in the management except. right? Now this answer is very straightforward. Psyllium husk, because psyllium is a fiber, right? It's a fiber supplement, and it can be useful for patients with constipation. Used for patients with constipation. Codeine known to cause constipation. We can use it. Theoretically, we don't use it now. Loperamide is most commonly prescribed drug, and cholestyramine can also be used for patients with diarrhea. In fact, especially patients who have this diabetic diarrhea, which we were discussing earlier, cholestyramine is a very good drug for that, right? So option B would be the answer here. Okay. Next question is Oslo definitions are related to. So basically, when you have patients with celiac disease, according to this Oslo definition, the celiac disease patients are classified into, right, whether they're symptomatic or asymptomatic. If they're symptomatic, they're classified into classical celiac disease and non-classical celiac disease. Non-classical celiac disease. Both of these are symptomatic, where they have symptoms of celiac disease. You will call it as classical when they have predominantly intestinal symptoms, and you will call it as non-classical if they have extra-intestinal symptoms. Intestinal symptoms. Okay. Then we have a category called subclinical celiac disease, and then you have a potential celiac disease. So there are 4 types of celiac disease according to the Oslo definitions. Now, what do you mean by subclinical celiac disease? Here you have the classical celiac antibodies positive, you have the histopath changes positive, but as I say subclinical, that means there are no symptoms. No symptoms. Okay. Now in potential celiac disease, I only have antibodies. These antibodies have not done sufficient damage, so histopathological changes are also not there. No histo changes, no symptoms. So if you found someone who only has the antibodies that you see in celiac, that is anti-TTG antibodies, right, anti-endomysial antibodies, if those antibodies are there, histopathology is normal, no symptom, that is potential celiac disease. Okay. Antibodies and histopathological changes both are there, but no symptoms, that is subclinical celiac disease. Once they start developing symptoms, it will be either classical if intestinal symptoms are predominant, or it will be non-classical if extra-intestinal symptoms are predominant. And this approach is what we call as Oslo definitions. So Oslo definitions are for celiac disease. Okay, next. Oculomasticatory myorrhythmia is seen in, right? So please remember Whipple's disease. We were talking about it in the very first question. Whipple disease do affect the brain, and that can lead to dementia and various manifestations. One of the neurological manifestation is oculomasticatory myorrhythmia. What happens here? There is contraction of muscles of mastication synchronized with eye movements. Right? Whenever patients are blinking or making the eye movements, synchronized with that, there is also contraction of the muscles of mastication. This is what we call as oculomasticatory myorrhythmia, and it is highly specific and diagnostic of Whipple disease. In that case, you don't need the past positive macrophages. Clinical suspicion plus oculomasticatory myorrhythmia, you can make the diagnosis. You don't need to go for any further investigation. This is highly diagnostic of Whipple's disease. This can also be a question. Whipple disease can be diagnosed without biopsy if which of the following symptom is present. Answer should be oculomasticatory myorrhythmia. Okay, next. Which of the following drug used for SLE management works by inhibiting interferon 1? Now please remember, interferon 1 is the main cytokine involved in SLE pathogenesis. We did not have any drugs targeting it, but last couple of years we have developed a drug which is called as anifrolumab, right? MAB because monoclonal antibody, right? Here IFR basically stands interferon, right? So it is an anti-interferon monoclonal antibody. That's why it's named as anifrolumab, right? So that will be my answer. Okay. What is this tofersen? Tofersen is the another newer drug which is used for treatment of the patients with frontotemporal dementia and amyotrophic lateral sclerosis. This is actually a monoclonal antibody against superoxide dismutase 1. So this will modulate, not a monoclonal antibody, it is a modulator of superoxide dismutase 1. Okay. Now istradefylline acts through adenosine 2 receptors, and it is used for patients with Parkinson's disease. It is for patients with Parkinson disease. Mepomycin is for the dyslipidemia. Right, so one monoclonal antibody for lipid disorder, one for a neurological disorder, another for neurological disorder, anifrolumab for SLE. Okay, next, nail fold capillaroscopy is used for the diagnosis of. Okay, what is nail fold capillaroscopy? Basically, we visualize the nail fold under the oil immersion microscopy, trying to look for the arrangement of capillaries. Now in the nail fold, normally capillaries are well organized like this. You will see loops of capillaries neatly organized. That is the normal nail fold capillaroscopy. Okay, but in those patients where there is vascular injury, there will be distortion of this nail fold capillaroscopy architecture. So you will see distorted architecture and you will see very large capillaries. Now these large capillaries are what you call them as giant capillaries. Apart from that giant capillaries, you can have areas of bleeding, right? So you can have hemorrhage. Then you can have avascular zones. So you can have areas where there is no capillaries, so we call them as avascular zones. So if you get this picture, this is abnormal, right? We report it as abnormal nail fold capillaroscopy. Now where is it useful? Where is the use of abnormal nail fold capillaroscopy? Basically to differentiate between the Raynaud's disease and secondary Raynaud's phenomenon. What is Raynaud's disease? Raynaud's disease is where on exposure to cold there is vasoconstriction and pallor, and that gets relieved little time later. But Raynaud's disease word is specifically used when you have no secondary cause. Basically what is happening is you have a normal physiological response to cold which is exaggerated, and it is seen in 5% of the general population. Right? You might have many relatives who experience it. On the other hand, when you say secondary Raynaud's phenomenon, there is a vessel injury, vasculitis, and because of that there is destruction of the capillaries, and so the blood flow through capillaries is already reduced. On exposure to cold, further reduction, and that triggers the pallor and the numbness, right? So now you tell me which one will have abnormal nail fold capillaroscopy? Obviously secondary Raynaud's phenomenon patient. And what is the most common cause for secondary Raynaud's phenomenon? The most common cause is scleroderma, right? So that is why we use it in the diagnosis of scleroderma. So NFC is normal in patients with Raynaud's disease, and NFC will be abnormal in patients with scleroderma or secondary Raynaud's. It will be abnormal in patients with secondary Raynaud's phenomenon, for which the most common cause is scleroderma. Okay. Now moving next, which of the following is associated with unilateral headache, raised ESR, and vision loss in an elderly? Every time you deal with a case of headache, right? First question, whenever you have a question on headache, the first thing that you should ask is it primary or secondary, right? So the question number one that needs to be addressed is whether it is primary versus secondary. Okay. Now when you say secondary, it is secondary to something, and generally that comes with, it is generally associated with red flag signs. Now what do I mean by red flag signs? The presence of these signs indicates an underlying pathology. One of them is like hypotension, projectile vomiting, hypertension, okay, unsteady gait. These all indicate that there is raised intracranial tension, right? Similarly, presentation in an altered sensorium, focal seizures indicates that there is an underlying problem. There may be a bleed or there may be a tumor. Similarly, fever indicates that there may be meningitis. So these pointers are something that we call as red flags. Okay. One of the red flag is elderly age, because elderly age, we have to think of many secondary causes, and another is the loss of vision. And typically if the question talks about elderly age and loss of vision, these are real red flag signs. And don't think of primary headache disorders in those conditions, but think of secondary. So I would clearly move away from migraine and cluster headaches here. And as we already know, migraine and cluster headache are typically common in 3rd to 4th decade. Same for the cluster headache. So the differential diagnosis or the only secondary headache mentioned here is temporal arteritis, which is also called as giant cell arteritis. So giant cell arteritis is a form of vasculitis, And there typically patients present with raised ESR, severe headaches which is unilateral, often accompanied by visual impairment. And when they have visual impairment, if you don't recognize and treat them early, it can lead to permanent vision loss. The treatment for temporal arteritis would be in the form of glucocorticoids, right? Glucocorticoids would be the treatment of choice. Okay, so that brings us to the end of all the questions. I understand that many questions were kept tricky or they were left to the debates. The reason for that is we should learn to address even the controversial questions. We should be able to make an inference or a conclusion even when the information is not sufficient to make a conclusive diagnosis. That was a take-home message. This was first part. We will also be connecting in the second part where we will take the more core systems, the cardiology, neurology and the respiratory medicine. That is where we will generally get clinically oriented questions. The questions are not going to be flat one-liners like we had today. So please connect with me on that. The PDF will be shared with you soon after this session is over. So solve those questions also and then we will discuss more. If you have any doubt, you can connect to me through the PW Telegram channel or my own Telegram channel, and I will be more than happy to solve your queries. Thank you guys. Have a good time and see you soon.